Pob, croeso and welcome to our board meeting. And we've got all mute on mic. Yeah, mic is muted, it says.
Should be on. Should be.
Just click on mute. I'm just thinking.
Pob, croeso and welcome to our board meeting. We have a very packed agenda, so I'll go straight into it at the moment. Any apologies for absence?
Yes, Chair, we've got apologies from Professor Philip Clare. Mr. Mark Henwood is representing Dr. Clare today. Mrs. Roth Jervis, Mr. Jonathan Griffiths, Dr. Mohammed Nazima, Mr. Mansell Bennett, the Chair of the Community Health Council, and I understand Dr. Barbara Wilson's on the call for Mansell, and Liz Carroll, our Director of Mental Health and Learning Disabilities.
Many thanks. And if I could welcome Dr. Henwood and Barbara to the meeting today. Any declarations of interest? No. If we go then on to the minutes of the public meeting held on the 27th of January 2022. Are the board happy with the accuracy of the minutes? Happy to approve them? Are there any issues that the board would like to raise in relation to the minutes? I'd like to raise it PM 21191. A workshop was being supposed to be held in relation to social care and healthcare and the people that we both serve and how we can assist in helping people to be in the right place at the right time together. And I just wondered, Steve, where are we with that at the moment?
Yeah, thank you, Chair. So a couple of things to say in relation to that. So we made the decision, given the local elections, that we would hold off the event until after the election, so that we have the new elected members in place for that, because this is going to require, I think, senior leadership from across all four organisations. It'd be helpful to have that in place. So we're planning it for either the middle of May or the early part of June, depending on people's diaries. I've got a meeting this next week with the team around how we're designing it. And I think the other thing to say is that I'm increasingly of the view that this will be the first of a number of workshops rather than just one. So it's still in training. We haven't got to where we could take place. I think we need to hold off until we've got the.
Thank you. That's very sensible. And I think, as we all know, our hospitals and our social care is under unprecedented pressure. It makes those series of working together meetings very, very important. Are there any other issues that people wish to raise under the minutes? Okay, if I can then go on to the matters, to the log. Are there any issues under the log? If I could draw attention to PM 2205, where it says that the Children and Young Persons Group commenced discussions regarding the detailed engagement plan. Feedback from this will be collated in due course. I just wondered if we got any idea of the date when we may have that feedback. Andrew?
Yeah, no, that's fine, Chair. We've discussed that through the Children and People Group, we will receive a regular report on the outcomes of the ongoing engagement and feedback processes that we've set up there. We were quite assured at the last meeting that they were extensive and would reach out to a number of key stakeholder groups and children. I will. We had to cancel the Children and People Group last week because of apologies for absence. So I will pick up at the next meeting where we are and get a report back that I can then maybe share with members. And I should apologise in the way the action's written, because it was supposed to reflect the fact that Delith is an observer on the group, not the and nothing more than that. It came over a bit blunt, I felt. So apologies for that.
Okay, Andrew, thank you very much. And if I could bring in Paul.
Thank you, Chair. Yes, on 2213, obviously there's quite a significant amount of money which is now going to be passing through the RPB, in respect of which the Health Board will be acting as banker. I was wondering what the governance arrangements are going to be, because as I understand it, within the RPB there's nothing equivalent to an internal audit function or something akin to the structured assessment that Wales Audit or the Audit Wales might undertake in respect to the Health Board. So I was just keen to understand how we're going to have oversight and assurance in relation to the way in which the money is being spent and achieving the objectives to which the money is intended to achieve.
If I could bring in Jill, please, and then Hugh.
Yes, thank you. And I think that's a very important question as we see more resource going through our regional arrangements, Paul. And I think there are two elements here. I think, as you rightly said, the Health Board will be the banker for this, and I would expect the Health Board actually to be subject to increased scrutiny as a consequence of that funding arrangement. So we will have to ensure that we've got robust arrangements in place in terms of that oversight with a finance partner, as we've now got identified for this funding. So that's one element of us as the banker. There is then the separate element of us as as one of the parties receiving funding for programmes, and again that will be subject to a separate arrangement, and there'll have to be a clear line actually between our role as the banker and our role as a partner in receipt of funding. There's always been, and I think we undertook some learning from the previous audit, but there has always been an arrangement for reporting into IAG and RPB in terms of the programmes that have been undertaken by all partners. That function has been increased. And as a consequence of the previous internal audit piece of work, discussions took place with our corporate team led by our board secretary and the regional programme manager for the RPB. There's been a change of personnel, so we're expecting to step that up again now to bring back the more robust internal governance arrangements, which we normally report through SDOD and into ARIC. You mentioned in your commentary around the Regional Integration Fund, which is the new funding. So we've taken an initial piece of work through the Strategic Development Committee. There'll be continued reports going through IEG, as there are currently for ICF and Transformation for each of the individual programmes, and that will go into the RPB and then partner organisations. Welsh Government also require monthly reports, and they also do undertake an external audit of all of the programmes. So I would see that there will be an increasing focus on the audit of this resource, and I would expect to take the first cut of that programme into SDOD once that final position has been agreed. We've signed off the initial piece of work last week at the RPB, so we expect to take that work into SDOD for that initial oversight, and I'm sure there'll be further work then that we'll take through internal audit in terms of both of our functions as this piece of work. But I think it's a really important question that you've raised.
Thanks, Paul. Hugh.
Chair, thank you. I think Jill has given a very comprehensive response there, but just add a couple of things. I guess the clarity that we now have through the Regional Integration Fund coming through the Health Board is very welcome, because I think that clarifies what was previously quite challenging with disparate funding streams coming through a number of routes. What we're currently working on now is what the memorandum of understanding will look like between partner organisations, because as Jill alludes to, I think those memoranda become really important as a route to secure good governance. But I'm very clear that as that money now is very, very transparently coming through the Health Board, that the responsibility falls on us to make sure that we can be assured that the money is applied appropriately and that the governance is checked appropriately. I think the conversation around who does the internal audit function and how we liaise with Audit Wales on this is still in discussion, and we'll bring something back to Audit Committee once, or ARAC, when we've got that nailed. But thank you.
Thank you, Jill, and thank you, Hugh. If I could also go on to PM 2206, a question from Professor John Gammon. Do we have an update on Carmarthen Hub? I expect that in particular the timelines. If I could bring in Lee on this.
Yes, absolutely, Chair. Thank you. And we have noticed in the note of the action updates the position with that. So we've had assurances from the County Council on the timelines and the urgency with which they're progressing it, but not in a position at this point to make public the precise timelines following the approval of the funding. So as it's a Carmarthenshire County Council scheme, we're we're waiting for them to finalise that, and obviously we'll advise board accordingly when they're in the position to do that.
Thank you, Lee. John, did you want to come in?
No, thank you very much for the update, Chair. Thank you, Liam.
Thank you. And then we have another question in the message bar from Delith about 2209. We're non-compliant with safeguarding. Are we confident that no child, young person is harmed due to this? I know we did ask that question at the last board meeting as well. So over to you, Mandy.
Yes, thank you for that. We're actually having a deep dive into safeguarding arrangements at our next quality committee. So in the meantime, I can give assurance that this is about paperwork being completed rather than the referrals actually being followed through, but that will come out now when we do the deep dive in our quality safety committee shortly.
Thank you, Mandy, and thank you, Delith. Are there any other questions on the action log? Thank you, colleagues. If we then go to the minutes of the corporate trustee meeting held on the 27th of January, does the board approve the minutes? Thank you. And if we go on to my report, I'd just like to say that we are under incredible pressure at the moment as a health board, as is probably every other health board and health trust in the UK. And on behalf of the board, I'd like to thank every member of staff who are responding so incredibly efficiently and compassionately to pressures, even after the last 2 years of intense pressure. In relation to my report, I have nothing further to add except very briefly. I'm proud that as a nation of sanctuary, that we in Wales are doing all we can to welcome refugees from Ukraine into our country, and we in our health board are also participating in that with all our partners, with humanity and compassion, and we're also supporting our staff from Ukraine and from Russia. And as with the rest of NHS Wales, we are also donating medical supplies to the people of Ukraine. I think one of the two highlights in the last 2 months for me was visiting the clinical research facility in Glangwili, the opening of it with Steve, our chief executive. I don't think we sing and we shout loudly enough about our research. I was absolutely amazed that we're 7th in the UK for COVID research. So we were part of the, leading in what drugs actually work on COVID and long COVID. And it also touched me how much work we'd done in the fertility area when all fertility treatment had stopped, and 40% of the participants in the clinical trial had managed to get pregnant. And the team were so enthusiastic and dedicated. And it was a very small facility we opened, but the fact they had a dedicated place made such a difference. And then I was really pleased last week to visit our new maternity ward. And I just want to pay tribute to everyone who has worked in substandard conditions with great care over the last 8 years. And you could visibly see how moved people were to have these facilities for the women of West Wales. And I understand mums and babies, hopefully new babies, went in Tuesday this week. So it was really lovely, on top of everything else, to be able to visit those two places. And obviously you can see in my report as well the continuing achievements of staff within our health board, and also the awards that people have received as nominated by their peers. So open to any questions. Okay, thank you. Is the board happy to accept the recommendations in my report? Many thanks. Then go on to the report of the Chief Executive. Over to you, Steve.
Thank you, Chair. Just to pick up your last point there, I did see a member of the team say around maternity, and they had 7 live births on the first day. So
how wonderful.
Hit the ground running, as always, so great to see.
Hopefully it was the afternoon, that's what they were wishing for.
Yeah, quite, but really good to see that after such a long period, as you say, of substandard accommodation for those staff and for our patients. So I won't say a huge amount about my report. Most of it is fairly self-explanatory, but as always, it gives a bit of an update on where we are as an exec team, as well as on national level issues. Just a few things I wanted the board to note particularly. Members will remember that following the discussion with the chairs of our committees, our executive team has now established a task and finish group to review and evaluate all of the service changes that have happened over the last 2 years, being led by the Director of Nursing. That group will make recommendations to the operations group on the proposed way forward for all of those changes, whether we sort of formalise them or move them back or something in between. And I would plan that the Quality and Safety Committee, with the Chair's permission, can provide oversight and assurance that those recommendations and the action being taken are appropriate. You will see a very detailed report, and thank you to Jill and the team for doing this around the home-based bridging service extension that we did. I have to say, I'm very proud of the fact that we did this, and I'm also very grateful to our partners in local authorities who supported this despite their very understandable concerns about what was happening and the potential downstream consequences. I'm also proud that we are now finding permanent roles for as many of those as we possibly can as we go into the new year. But picking up the question in the table of actions, it's more urgent than ever that we find a long-term solution in West Wales for generally care at home, whether that's NHS or our partners' provision. And I'll come on in my later report, and I know Andrew will want to say a little on this as well, just about those pressures that we are currently facing and what that's meaning for our staff and our patients. You'll see an update on our escalation status. It was good to see that we've been maintained at the second level of enhanced monitoring, just up from the routine monitoring, and we are working hard to get to secure that level 1 position, which I'm hopeful that we will be able to do, subject to our IMTP getting support from Welsh Government in the next few months, but still a lot to play for there. And you'll also see that we put up the draft terms of reference, which have now been published across the UK for the UK-wide COVID-19 inquiry, Appendix F. We've included some updates and additions that we'd like to see that have been suggested by our local group, many of which are already included in the terms of reference following discussions with the Welsh Government team, but would welcome both board support for those changes, and in particular for wanting to see the Penally camp included in the terms of reference. So would just want to tweak the recommendation slightly rather than just note to support that as a board, so we can then move forward in our discussions with Welsh Government and on the UK basis. And just finally on the review of capacity across the ambulance services, just to note today that we did commit that when that review was done around capacity, that we would take that back to our local political meeting with the outcome. So I will be picking it up with the Chief Executive of the Ambulance Trust to join us for one of those political meetings so that we can go through the consequences for West Wales.
Thank you, Steve. If I go over to the questions, if I could bring in Andrew first, if I may, who said we will give an update on the pressures.
Oh, I was going to do that under my
on your report.
The other report.
Okay, we'll wait to the second report then. I'll bring in Judith and then John.
Yes, thank you. Thank you, Steve, for the report. I just wanted to echo what you said about the home-based bridging service report. It's a very, very informative report. I suppose one main question I had was to do with the recruitment process, and mindful of the process that was used during COVID when we onboarded so many staff through a shortened process. I just wondered if consideration was given to that, or even consideration to doing that in the future, in terms of looking at a very maybe shortened process to enable us to maybe act more swiftly in these scenarios. Also to say, very pleased to hear that those who were taken on are being offered opportunities to stay within the organisations. Thank you.
Jill may want to respond on that.
Jill.
Yes, thank you very much. And again, you know, I've always enthused about this, and I think despite all of the challenges, I still celebrate the fact that we've got 22 people who have joined our service and have been offered permanent roles, and they have added value to the points of the service that they have joined. So we welcome that. Just to confirm, actually, Judith, that swift recruitment fast track process was used. I think, however, there were delays sometimes in the candidate's ability. They had to still give notice, even if they were recruited recruited quickly, and so sometimes that fast track doesn't always work for other reasons. And then there were other delays for some candidates in producing documents, etc., which meant that the recruitment process actually took more months than we'd anticipated. So that was the challenge in the end.
Thanks, Jill. There's another couple of questions on the bridging stuff that I could bring in. I think it's Paul and Gareth.
Thanks, Chair. Yeah, again on the bridging service, Jill, obviously the number of people that we managed to recruit into the service was perhaps not what we hoped or anticipated at the outset, and I was wondering if there's any learning which we got from that we can take forward as to where we might be on other recruitment initiatives which the Health Board might be undertaking.
Yeah, I think there are a number of issues, and thank you for raising that, Paul. Firstly, I think short-term recruitment for this sort of work, we know why we did it, because this was about us supporting a real challenge in the service, which was for essentially a service that local authorities needed to provide, that was domiciliary care, and we agreed that we would extend our community services to try to support that. So by the very nature of it, these were fixed-term, short-term appointments, and I think that's always a challenge for individuals in terms of accepting that. And I think one of the learning points, and particularly when we talk about the service pressures that we will do shortly, is that we need a really long-term solution in terms of our community services, both for the registered service of domiciliary care, but also for our community services more generally. And that's something that Andrew and I have been talking about actively over the last few days with Lisa, and how we do that actually. The other point I think that I must raise is that we went out to advert also at a time when there was a lot of competition from other areas, so both internally, and we had that conversation, there was a lot of recruitment going on for housekeeping services, etc., so for not necessarily the same roles but for roles of similar grades. And also then our local authorities equally went out for extensions of service into their own domiciliary care service, so I think there was a lot of competition at that time for roles of a similar grade. So I think there is some learning around that. We've also undertaken a piece of work across the Regional Partnership Board to look at the lessons learnt, where people have left the service, where people have joined the service in terms of what adds value. And I think trying to change the nature from the type of service that domiciliary care is, or these type of community roles now, where the interface with the client may be very short, the engagement with the team may be disjointed, that feeling of part of wider service may not be there in terms of that team focus. So a lot of that learning has been taken through the Regional Partnership Board and the Regional Workforce Board to think about how we create a career structure around this, to offer much more of an incentive to individuals that allows them a career development path, but also enables to support them as part of a team and the wider delivery of our community services. So I think there are really some very important issues that we've learnt here, and it's the wider terms and conditions, and not just pay, but that has been looked at as well, and that's certainly been taken on board both nationally and locally. So quite a lot of learning has come out of this.
Thanks, Jill. And I'm going to bring in Gareth on a similar area, and then Maynard.
Yes, thank you, Chair. Thank you, and thank you, Jill. I noticed in the report from the local authority perspective, you haven't been able to demonstrate really that's had a direct positive impact. It's certainly been confirmed there hasn't been a negative, which is really reassuring. My question really is, can I take it as read that this will be one of the top agenda items in the forthcoming discussions between the Health Board and local authorities, hopefully at the end of May?
Absolutely, and I think this was really part of the core issue that started some of the conversations around the need for that wider development. But I think, as the Chair and Chief Executive have referred to, what we want to look at is a piece of work that we consider: how do we deliver services together? How do we collaborate over the important areas of service that we need to deliver for our population? So it may be about domiciliary care, but it's actually going to be about a much wider issue around how we deliver services jointly. And perhaps I would take I wouldn't necessarily agree totally with the fact that our local authorities think that this hasn't had a positive impact. I think what we haven't been able to do over a longer period of time is demonstrate the value of this working together. And I think we knew from the outset we could not deliver domiciliary care as a registered service. What we wanted to do was to enhance our community services, and we very much did that, even in the roles in which the individuals delivered in the short time. It made a real difference to a number of patients receiving care. We were able to increase runs, we were able to increase the capacity of individuals receiving care. And if I just think about Pembrokeshire as an example, where we had perhaps some of the greater numbers, we were able to increase the number of clients that we saw as a consequence of adding those individuals to the team. So I hope it has had a positive impact all round, and particularly for the patients who've received that care.
Thank you, Jill. Thank you very much.
Jill, I'm just sorry, Maynard, but I'm just going to bring in Steve on the same point, if I may, and then over to you.
Yeah, I think it is a really interesting point. I think for me, Gav, there are two things that probably we need to think about in relation to the workshop. The first is it's really clear that actually what we need to do is act at scale. And actually, you know, it was challenging for us because for the reasons Jill said, we didn't get as many people as we would hope. That probably led to it being quite difficult to identify specific measurable system benefits. But the other benefit, which I think we saw, it'd be interesting to see if Jill and Andrew agree, was the psychological impact on our staff, the fact that we were trying to do something different. And I think that helped to show that we were on their side. And actually, as you recall, we probably were the only place in Wales that went this far, this quickly, and others were looking to us. So that's why I'm proud, even if the effects can't be measured in the way that we might hope, and with the specificity we would hope, that actually it did show that we were trying to do our very best in a very difficult situation.
Yeah, thanks, Steve. I totally agree with that. And you know, this workshop that we're going to have, or a number of workshops, are absolutely critical. I think we can work together in West Wales to put things in place to improve the experience of the population that we all serve quicker than perhaps may otherwise be the case. And there's a lot of learning from that, and I'm proud that we had the courage to do it. Maynard.
Thanks, Chair. Just one final thing on the bridging service. A lot of conclusions there and a very helpful report. I just wanted to clarify where in the Health Board these are going to be taken forward. I'm assuming it's probably going to be the Strategic Development Committee.
Yes, I would imagine that, and we've brought earlier discussions into that committee, but also probably the People Committee as well, I think, in terms of how we take forward that joint work. And Lisa is one of the joint chairs of the Regional Workforce Board, so I think it would be really important that we're considering that workforce component through that as well, but very much joining up the service and the workforce agenda, as you suggest, Maynard.
Thanks very much, Jill. One other question, if I may, Chair, on a different subject.
Yes, please.
Yeah, regarding the buildings that we are now leasing, just wanted to clarify how those buildings were identified and what competitive process went through in identifying those and negotiating the leases.
You.
Yeah, I'm happy to come in. Absolutely. I think the two buildings that you refer to there were identified as part of kind of the ongoing response. I think I don't know if Alison's on who may be able to comment on the buildings themselves, but in terms of the process then of approving, they went through the normal scheme of delegation approval process. But in terms of the identification of the building, I'm going to have to defer to operational colleagues for the identification of the location.
Thanks, you.
Maynard, did you have any other questions?
No, that's it for me, thanks.
Oh, thank you. If I could bring in Professor Gannon, please.
Thank you, Chair. I guess it's to develop the point that Paul has made in terms of the draft terms of reference for the COVID public inquiry. I'm not too sure why one of the terms of reference relates to outbreaks in universities and its impact on health services. My suggestion as a board is that we recommend that should be tertiary education, to include FE and schools. It's wider than just universities. Thank you.
John, since the paper was written and those meetings took place, there was also a meeting with Joe and Sean Marie and our legal advisor, so I'll bring Joe in on that point if I may.
Yeah, thank you, Chair. So we had a long conversation on Tuesday evening regarding the terms of reference, and we've taken specific legal advice out on these, and the areas that were called out within the what we've included in the Chief Exec's paper are actually under section 1 of the UK inquiry terms of reference anyway. Terms of reference for the inquiry are really wide, as you can already see, when we work through the process of the specific impact of these decisions for the Health Board. When working through it, the one area, I know you called universities, John, and I do think that's covered already within them, so we wouldn't be recommending that any further is added from that perspective. The one area we felt was specific for Howard during the pandemic was in relation to the Penally Army Camp, which was a specific different issue for us here than for colleagues in, I think there's one colleague in England, but not for colleagues across Wales. So we do think that universities, children and young people are already covered within the terms of reference, Chair.
Yeah, thanks, Joe. They're very wide, John, but it's implied. And I think it's up to those people who participate to raise the specifics, except for Penally Camp, and I'll come to that at the end. Are there any other questions for the Chief Executive, please? The board happy to accept the recommendations with an added one that we make representations specifically in relation to the terms of reference of the COVID public inquiry to include the impact of government decisions in relation to moving asylum seekers, hundreds of them, to Penally Camp between September and March, and that is considered as part of the inquiry. And I'm hoping that the other health boards in Wales will also support that. So if the board's happy to support that as well, we'll take that forward.
And they'll submit as our own legal entity, Chair. That would be, immigration is included, but we will add that. That was as our response, Chair.
Many thanks. Thank you. Thanks, everybody. We go on to the next item of the agenda. It's the report of the Audit and Risk Assurance Committee. Over to you.
Thank you, Chair. Yes, it's the report from the meeting of the 22nd of February. The report obviously covers the issues that were discussed at the meeting. You'll see that there are a number of items which were internal audit report items which were deferred. The reasons for that are diverse. There's not one single reason. Some were deferred as a consequence of difficulties for the internal audit team in being able to undertake the work because of the service pressures that the different parts of the organisation were experiencing because of COVID and other pressures. Some of it was as a consequence of deliberate decision to defer some work until next year in order that we can have a more detailed report on those issues. And some were just sort of administrative problems in getting the reports to the committee in time by the cut-off date. I had a meeting with the head of internal audit yesterday, and I'm assured that some of this backlog is going to be covered off at the next meeting of the audit committee. So we will hopefully be in a better place once those reports have come to the committee. Subject to that, you'll see at the end of the report a number of issues which we're highlighting. It was obviously pleasing to note particularly the progress which has now been made in relation to records management. There's been a push on this, I think, from the autumn of last year, but it would be fair to say there's been some delays in getting us to that place, and for that reason the committee felt it was appropriate that we kept an eye on this, as it were, with a request for further updates and an action plan as to how the work is going to be taken forward with specific timescales. So that's the report, Chair. I'm happy to answer any questions.
Many thanks, Paul. Do members have any questions? Okay, thank you for all the work of the committee in keeping us safe. Next item on the agenda is the Quality, Safety and Experience Committee. Over to you, Anna.
Thank you, Chair. So this is the report from our meeting on the 8th of February, and there are just two matters I draw the board's attention to from the report and one additional matter, please. So if we move to the key risks and matters of concern, the committee took a close look at the staffing position around health visiting, with particular reference to very fragile workforce arrangements in Pembrokeshire and Ceredigion. And I understand this is similar to a picture across Wales in terms of workforce pressures in health visiting, but in our local area particularly exacerbated around now as a result of a number of retirements in services in Ceredigion, and inevitably this is impacting on service delivery. And while colleagues from Carmarthenshire are doing their level best to pull out all the stops, we remain in quite a fragile position in terms of risks in that health visiting service. We were assured as a committee that there is a very clear focus right through to executive level on this issue, and the committee agreed that it would receive an update in August. So at this point it is not a formal escalation to board, but it is really to put it on the board's radar to say that we are taking a close interest in this area, and will update further in due course. The second matter for concern concerns cardiac pathways into Swansea Bay, and particularly non-STEMI interventions, which is this angle. This issue is particularly about our rural geography and what that means for timely inter-hospital transfers from our hospitals into Swansea Bay. There is ongoing work to try with the Ambulance Trust to try to improve those arrangements, but as a committee I think we felt that there probably were some residual infrastructure gaps that allowed us only to take limited assurance that significant improvements were possible to make. If I can make one brief additional comment here, I'm sure that we all saw yesterday the publication of the Ockenden report for Shrewsbury and Telford in regard to maternity services, and I wanted to assure the board that in April we are taking a review of our maternity services through our committee to include a follow-up on the lessons to come out of the CMTAF review a year or two ago, and Mandy may want to comment on how we're going to incorporate the Ockenden learning through that process. We've had a bit of conversation about that this morning, but may I also suggest that in addition to looking at the clinical practice issues through our Quality and Safety Committee, we also consider as a board what learnings we might take, and open and very keen really to hear your Vice Chair and the Board Secretary's advice in due course as to how we consider learning that would be relevant in terms of governance assurance for us to consider at a board level, please. Mandy probably wants to come in on the maternity issue. Thank you.
Dan and Mandy.
Thank you. So yes, I've spoken to our head of midwifery, who's new to the organisation this morning, and I'm advised that there is an all Wales piece of work where there's going to be a structured template that's developed for all maternity services to complete, which will cross-reference the various reports that have identified learning for maternity services. Having looked very quickly at the governance element of the Ockenden report that's been pulled out, I don't think there's going to be any surprises around any issues or themes that we're going to have to look at afresh. That said, as Anna has said, we do have the deep dive going on into maternity services at our next board and at our next quality committee, and indeed a patient story as well, which will be very helpful to keep us grounded and levelled in terms of our experience of our maternity service users, but also a very brief summary of where we believe we are against the Ockenden report, with a further quality panel that will take place at the end of April, and then a more detailed report for assurance purposes back into the quality committee in June. So hopefully that will then be able to provide both through the quality committee and through to board that we're able to know exactly where we are and any areas that we still need to take any further action in.
Both, and like everybody in the country, it's absolutely shocking and terribly distressing to see and hear about the experience of mothers and the children who survived with disabilities and the children that were lost. And I really welcome what you said, Anna, about discussing with the board secretary about how we as a board go forward. For me, it's an issue of culture, and it's an issue of speaking up safely and listening to staff, which is a board responsibility. So as well as the clinical and the deep dive into our own maternity services, I'd like to broaden that into how is our speaking up safely being embedded, what sort of things are we hearing, how do we continue the journey of encouraging people to speak up and knowing that they will be listened to and welcomed, and we will act upon it. But yeah, thank you for raising that under your report as well. And thank you, Mandy. I know our new head of midwifery is very, very experienced as well. I know Jennifer asked a question about that. Can I go back to the one thing that you did that is in the committee report about cardiac services, pathways, delays? Now, I know it hasn't been escalated to board, but it is continuing to be a matter of concern. And I just wonder what your advice is, how we take this forward.
Well, I don't know if I don't think Phil is here today, is he? But I don't know if any exec colleagues can provide any update on that. But I mean, from a Quality and Safety Committee point of view, I think we'd certainly want to keep a close eye on this, and it's part of a wider picture around cardiac access at a tertiary level for our or specialist level for our patients in West Wales. So it is part of a bigger picture that is very much on our radar. But I can see Mandy's come back on screen, so may have an update for us.
Yes, thank you. And it's just to provide assurance as well that there is a significant amount of work going on with our colleagues in Swansea Bay as part of the Cardiac Transformation of Services programme that's being undertaken. As well as that, we're also making sure that the commissioning element and the performance, putting a hard spin on it, the performance element of it is also being picked up through our commissioning discussions with Swansea Bay as well. So it's being looked at from multiple avenues, but certainly it will be something we'll be taking back into the Quality Committee as well for a further update later on this year.
Anybody else have any questions on the report from the committee? If I could just go to Steve.
Just a couple of things, if I may. I think the chair's covered much of what I was going to say around the Ockenden 2 report. This, of course, our second report into maternity care. For me, I think what comes out of it were 3 issues that came together to make the situation as awful as it was. And we need to make sure we're cognizant of all 3 of those in our organisation. I think the one that no organisations is safe from is the pressure on staffing and our ability to be able to fully staff our departments. I think that is something we all need to be cognizant of and recognise, but it is the world we're in. But the other 2 that she highlighted are things that I think are very much in our gift. So the first is not to have an over focus on performance and targets, because that creates a culture of people not wanting to speak up or feeling they have to put a gloss on things. I think our improving together work should be our antidote to that, but it's something we need to, as we roll that out, ensure that it is creating the right atmosphere around performance and getting that balance right. And as the chair said, the third part that came together in that trust was the culture, both for staff feeling they can speak up safely, but also for patients and their families to be able to give their views as well. And that's, again, something else which is entirely in our gift. And I think we do have some work on. I would absolutely support your comments about looking at how well that's embedded. On the other issue around NSTEMI, Mandy's sort of covered, I think, the performance, the way in which we're going to try and manage this performance better for our patients. And there are a number of opportunities, I think. I just wanted to sort of put a marker down there. I think as an organisation we can be much more ambitious, particularly as we build the outline business case for the new hospital. There are places in the world who are more rural than us, who deliver these timescales much shorter than 72 hours. So there's just something to have in our minds about the 72-hour target is sort of, it's a thing that we should try and ensure that we get to in the short term. In the medium term, we should sort of remove it from our minds and say, actually, how can we do this much more quickly? Because actually we know there is a real time element to all of this. So as we build all of those pathways that are going to support the new hospital and the repurposing, actually what are our opportunity to do things completely differently in relation to some of these, so that actually we create the best service, not just a service that hits the target. So it's just something for us to have in mind.
Great. Those you with then hope for the new way forward. So thank you, Anna. If I then go on to the next item on the agenda, it's the board assurance framework.
Yeah,
Over to Joe.
Yeah, so I'm not going to go to the detail of the report or the dashboard because that's been there for members to do that before the meeting. But just to call out, we will, as we develop the MTP and following the July board, the back will obviously change as any planning objectives change, and that will have some into any outcome measures we change as well. But just to give a summary, there's 5 planning objectives complete, one's ahead of schedule, and there's no change on the others. So there's 32 on track and 15 behind schedule. These are being monitored through our committees, and particularly for SDOC, who have a number of planning objectives we've now planned in the deep dives, and when those will be reviewed over the next 12 months, Chair.
Many thanks, Joe. Any questions on this?
Just one, it's more just a comment. I mentioned it in my paper that follows, but we will be bringing a closure report around our recovery plan for 21-22 to board in May, so that we can see what's happened with all of those planning objectives and also which ones are carrying forward into the new year. So we've got a sense of where we've got to.
Thank you. Maynard.
Thanks, Chair. On strategic objective one of the ways we are monitoring things in there is staff survey. Noticed a slight decline in response between December and January. And the response rates were 23% and 20% respectively. This is fairly low, but fairly standard for surveys, I understand. But I'm just wondering what we can do to improve that response so we get a better handle on things.
That's Maynard. Lisa.
Thank you, and thank you, Maynard. They are fairly low response rates. However, it is higher than the All-Well survey that we did in 2020, which was 17%. The other thing that we recognise is it's the first time we've done these surveys, and it was during the winter pressures period. So there are things that we have to take into consideration. However, we are developing a communication strategy because we are aware that some of the surveys were hitting people's inboxes and they weren't quite understanding the significance of why they were being asked their questions. So our OD relationship managers are doing work with our services and with our staff around the importance if somebody gets an email, because the plan is that we reach every member of staff in 12 months, that they will complete the survey. We're also planning some organisational development work whereby an exec and an independent member will be jointly doing video broadcasts to our organisation to ask staff to complete surveys. So we're going to pick themes and topics so that we can all play a part in helping staff to understand that we really want to hear what it feels like and really want to do something about it. So we'll also be following it up with a you've said this is what we've done, so that people can see that actions will be taken. So the other thing that we've begun to do as well is we're promoting it now on our staff benefits app. So we know it's something that is very frequently seen by staff. So we're trying a whole range of different communication methods to reach all areas of the organisation, and particularly linking in with domestic supervisors, estates managers, where they're more difficult to reach through our traditional methods.
Thanks, Lisa, that's really helpful.
Thank you very much. Any other questions on the board assurance framework? Just reading Hugh's message, it says triangulate the data from strategic objective 1 surveys with the quality and harm dashboard that we're developing will also provide powerful assurance as part of our response to the Uppington findings. Thanks, Hugh. Okay, thanks, Joe, for the report. If we now go on to making a difference, which is update the customer service programme. No, excuse me, I've missed 3.11, which is the improving patient experience report, which is Mandy.
Thank you, Chair. Threw me a little minute then. I thought, gosh, I thought I was on next, but here we are. I'm here.
Mandy, it's my favourite report as well.
Oh, thank you. So I'm pleased again to be able to provide this report, and this time I just want to spend a few minutes focusing on the story that we've identified on page 2 of the report. And I'd particularly like to thank Lee Mills and his family for sharing the experience of the death of his late wife Laura, and indeed of the impact that that death had on the entire family. So whilst Lee so generously thanked the district nursing team and the palliative care nurses for their kindness and their compassion, he did also point us in the direction of opportunities to further improve our services. We do really only get one chance to support someone in the last days of their life, and this is why we will be receiving the palliative and end-of-life care strategy later in this board meeting. The review of those services was commissioned some time ago, and actually we have got some further improvements which I know Jill will be sharing with us later on. But keeping people and the individual person's expectations and experience at the heart of everything we do is so important, and hopefully this has been reflected in this month's experience report that's being presented here today. So one of the things I did want to say was that our ability to capture feedback has undoubtedly been affected during the pandemic because of the ways we've had to change and develop and deliver our services so differently. But it's also had an impact in terms of the introduction of the new All Once for Wales Civica system, which I've mentioned at several board meetings. I'm pleased to say that we are rolling that system out successfully across the organisation. We're not totally there yet, but we're working on that. Nevertheless, I'd hope that you would see that within this report we've been bold to offer both the positive and the negative results from the services that we provide across all age ranges, particularly in pages 9 to 13 and again in 17 to 21. Very frank and honest conversations that are direct lifts from the feedback that we receive from people that use our services. Behind this report, however, goes a lot of analysis of the data that we provide, and we monitor patterns of complaints and compliments that are received across the services. We also undertake deep dives into the information that we receive, particularly into areas where we might be seeing a bit of a hotspot glowing, so that we can understand exactly what is going on there, and look at staff experience reports, external reports, and of course undertake quality visits ourselves to ensure that we know exactly what is going on. All of our services are given access to the system, and the new Civica service, very excitingly, will push out reports to every single clinical area that is using the system, and that will help us further to make sure that we've got really clear and robust, you said we did, boards at the front entrances of the services that we're gaining feedback on. The other thing that I just want to very briefly draw the board's attention to are the wide and diverse range of activities that are being undertaken by our arts in health facilitators. I can't believe, I said it last month and I'll say it again this month, I can't believe that in such a short period of time they are making such a big impact. Not just on our staff, but also patients and those that are visiting our hospitals as well. And that's on page 24 onwards. So I'm going to pause there, and I'm more than happy to take questions. Sorry, I've got a bit of a frog in my throat, so I'll do my best. Thank you.
Have some water, Mandy, and I'll open for questions. Maynard has a question on patient feedback on paediatrics.
Yeah, Mandy, on page 9 of the report, there's a table of the feedback on various departments, and most of them are fairly level. Some show improvement since the start, but paediatrics takes a fairly significant drop in the last month between January and February. Dropping from 84% to 66%, and even dropping from 100% back last October. I was just wondering whether we've got any idea of what's going on there.
Yes, thank you for that. And I was talking to the senior nurse for paediatrics only yesterday to try and find out exactly what is going on. And it does appear that there's been a bit of a hiccup in terms of the QR code that's being used on the various sites, that they still were linking into the old systems. That's been addressed now. The other thing to say is that they they don't always, parents and children don't always use the FFT system, the friends and family system, which this information relates to, but they do have other mechanisms in place to capture feedback as well. It only takes a very small variation in numbers. So what you're seeing here is a small variation in people actually completing the survey, and then that's translating. So if you're getting 1 or 2 people using the FFT system, that can skew significantly as opposed to perhaps 50 people the month before. But they are using a traffic light system. I did check with them yesterday whether they were using the pants and tops system that they had in place for the children in particular, but they've moved on to a traffic light system now. So that is visibly displayed in the clinical area as well. But we're working on how we can make sure that we're capturing all of that information and feedback, as well as the FFT results as well.
Okay, thanks, Mandy.
Thanks, Mandy. There's a number of questions. I bring in Judith, then Derek, and then Anna.
Thank you, Chair. Thank you, Mandy. I think, oh gosh, I've caught your frog now. Excuse me. Excellent report. Yeah, like you, I was amazed at the work with our artists. It's incredible. I wanted to ask a question actually about inquests, and just asking where the outcomes and the lessons learnt from any coroner's inquest, how they feed in, because you mentioned the Ombudsman, but I obviously Mandy to ask it because we've had a recent one concerning an incident within mental health, so I just wanted to ask that question, please.
Yes, absolutely. And in terms of inquests, they do go through listening and learning subcommittee. And obviously, because we're focusing around very much the experience and the feedback that we're getting, we haven't included them routinely within this experience report. The learning, however, from our inquest is something that, again, Louise, who's responsible for this area, is looking at how we pull together a group to actually make sure that we are using and triangulating the learning from the inquest equally into the feedback that we're getting as well. So they are captured, the themes are responded to as well.
Thank you.
Janet.
Thank you, Chair. Thank you, Mandy. I've got one positive and one query actually. The query is about this report is mainly about acute sites. What about our feedback for our community settings and primary care? Because it is very, very much hospital based. So that's the question. The positive I've got is the feedback from an autistic patient's family and the care they've received in Glangwili and further on in the report in Bronglais. So are we capturing good practice as well, and are we disseminating that? Diolch.
Absolutely, and thank you for those questions. So you'll recall at the last board meeting we did actually provide some input in or some feedback from primary care and where we could capture the community as well. It is work in progress within community because obviously I'm sure like everybody else we all get a little bit fatigued of answering surveys and providing our feedback on the services that we use. But it is something that we'll continue to strive, and perhaps next time we'll see if we can have an even greater focus around community. But I can assure you we are taking every effort we can to capture feedback from every service, regardless of where it's delivered as well.
Thank you. If I could bring in Anna.
Thank you, Chair. Mandy, from time to time in amongst all the different kinds of feedback that we get, there's a nugget of information that might alert us to a potentially significant incident. I'm just wondering when that happens, how do we make sure that we don't lose that alert and cross-refer it into the right place for follow-up?
Thank you. So depending upon what the matter is, so for example, within the report, we've actually made reference to a sepsis issue. And that individual who left that feedback has also left contact details. So that will be followed through the concerns team in the first instance before even the service get that feedback, because obviously there may be a delay from it coming in to the point at which it actually reaches the service. So in that respect, if there's something that the team can pick up and run with straight away, they will. So there is contact being made with that particular family. In terms of any other issues, if there is something that is appearing to be a bit of a theme or a trend, again, there's a conversation directly with the particular service lead so that we can understand in greater detail what is going on and we can pick those issues up. So hopefully that addresses your query.
Thanks very much, Mandy.
Thank you. If I could bring in Donna Coleman, who wishes to raise a query on paediatrics as well.
Yes, it's just a quick query, please, regarding the feedback on the report. We've got one down for Withybush General Hospital, the Paediatric Ambulatory Care Unit. Can I assume that should have been for Glangwili? Because my understanding is that PACU has not been operating, and I think these are comments from the past 2 months. So it's just a point of clarity there, please.
Donna, I'll have to go back and exactly check to see whether there has been a specific issue. Obviously, we have still had 1 or 2 children appearing in Withybush and having to be either dealt with immediately there and then transferred up or signposted up. But I will check and come back to you to confirm.
OK, that's lovely. Thank you very much.
Thank you very thanks, Mandy, and thanks, Donna. Are there any other questions on the report? No, I just want to say, Mandy, I say it at each board meeting, but particularly during the pandemic, particularly in the light of the report that came out yesterday from Shrewsbury, it's so important that we have as many mechanisms as we have at the moment, that we bring the voices of a range of patients to the board as best we can. So could you please thank the team and thank the arts and health coordinators who, like everyone else has said, they are you've really taken things forward and, you know, filling a lot of gaps and doing lots of innovative work where it's needed. So thank you. If we then go on to the next report, it's Making a Difference Customer Service Programme. And over to you, Lisa.
Chair, just post that Lisa has got internet connections at the minute, so just in case we lose her.
Okay.
She's back now.
Okay, Lisa. See how far we get.
Okay, thank you. Thank you. I just had to run outside to tell Joe I'd lost my internet, so hopefully it will stay with us. I'm delighted to present you the paper today around the Making a Difference Customer Service Programme. So as you know, over the last 12 months, we've been working on a programme of how we can deliver customer service training within the organisation, and we have been far afield virtually looking for best practice in terms of the delivery of customer care. The outcome of that is that it isn't just about customer care. You can't care for others if you don't care for yourself. So actually our programme has now become Making a Difference, and it's how you make a difference to our patients, our public, our colleagues and ourselves. So the report that you have today has already been to the People Committee, so John would be able to give some assurance around the conversations that we've had there. We have run a pilot of the programme, so we were testing it out, and some of the feedback that we've had already from the programme are it's suitable for all individuals. So we've had a range of staff attending. Everybody felt it was suitable and tailored to their needs. It gave them access to help. People also felt a series of the organisation wanting to invest time in them. So it was a very relaxed, very different training experience. This wasn't about training people about particular you know, technical elements of how to deliver customer care. It was about sharing experiences, sharing how people feel and behave with others. People felt that it gave them an opportunity to reflect, and they were given a very simplistic framework within which to deal with complaints and to help people when they are having difficulty. We've also had feedback from people that it made them aware of how their behaviour impacted on others. So that's some of the feedback that we've had initially. The programme will be delivered throughout the year in a variety of settings across the whole of our organisation. Dates have already become available for people to attend the programme, and we're really pleased that we've already got 123 people booked on to that programme from all areas of the Health Board. Attendance can be a challenge because, as you mentioned earlier, the pressures that we have on the system at the moment. However, by engaging with people around what we will get from that training programme, we'll just flex and adapt as we need to. The idea is that everybody will go through this programme, and therefore by looking at the new behaviours and the way that we work and the way we communicate with each other, it will become sustainable for the future. In terms of so what, so we put a programme in place. What's going to be different? What we would like to see being different is that what you will have read in the patient experience report, just some of those negative comments around how people have felt whilst they're receiving our services, that some of that will change. We're hoping that that will reduce. We're hoping that people will be more confident to deal with things as they see them arise. They will also feel more confident in how they are able to address an issue that a person raises with them. People have already commented through that pilot phase around how they can see that their personal development also has an impact on patient experience. Therefore, we're hoping to see outcomes in terms of our performance appraisal process and also our lifelong learning programme and how we invest in staff in terms of their future development. The other key thing about this programme is it won't stop after the day. So there will be a process whereby within 4 weeks and then 6 months of people attending the programme, we'll be going back to them to say, so how are you feeling now? What's changed? Have you noticed an improvement? So we can start to capture more of that softer intelligence as well as some of the key metrics in terms of the difference that it has made to people. Every member of staff, as I said earlier, will be required to attend or will be attending, and they will be given a whole toolkit of things to support them through the process. So I'm happy for John to add any further comments and to answer any questions that anybody has.
Many thanks, Lisa. I'll go over to John.
So, Chair, this paper and programme for making a difference, which addresses one of the objectives that I think it's 1C, I think it is, as a planning objective, was scrutinised at the People and OD Committee. What I would say is that overall it was certainly welcomed because of the reasons that Lisa has obviously said in terms of how we support staff to communicate and care for our patients. It was welcomed that it's based on evidence and that there's been scrutiny of evidence, not just nationally but internationally, in order to inform the programme. However, there was concern about release of staff and the time that is required in order for staff to undertake this. We did get some assurance from that, and obviously Lisa has given us some idea of how that's going to be managed. There are clear next steps, and certainly as far as the committee is concerned, we will be monitoring those next steps and certainly looking as an organisation for impact and outcomes and how that's going to be measured in terms of the programme that's been developed.
Thank you, John. Thank you. And I'm going to bring in Steve.
Yeah, just on that sustainability point more generally, when I see this as becoming part of our core business, how we support and help staff to think about how they relate to patients, to each other, and also to themselves. As Lisa said, this is much about supporting our staff in their day jobs. So I don't see it really as a kind of nice to have add-on, because we spend every day interacting as human beings with other human beings, and actually by doing this over the long term, whilst we do have to have some metrics and see whether there are ways that we can measure the impact, actually this is about changing the climate in the organisation, which then leads to change in the culture. So I think it's really important. I think the board does need to keep an eye on how it's going. I said if the BAF works as it should be those indicators that start to shift as a result of this and a number of other things. But we probably won't be able to pin it on any one thing. It'll be a whole set of actions, including this one. But I just see this as so important to the way that this organisation is perceived, both by its staff and by the population it serves.
Totally agree. I'm going to bring Anna's got a question in the question bar, so I'll bring you in, Anna, then I'll bring in Paul.
thank you, Chair. Lisa, it's just I wonder if you could just say a little bit more about those anticipated outcomes, particularly from a customer or patient point of view, that you described, how we might actually measure those so that we can be clear on the success of the programme, please.
Yeah, thank you. And some of that is going to be difficult, but what it will be is when we look at how Mandy's team and how the rest of our services collect information from patients about how they have been made to feel or whether they've had access to information. What we would like to see is less of the people didn't think that I needed to sleep, or you know, people were rude to me, that we lose that kind of feedback around our staff, and the negative comments that we get through it are more about our service provision and our environment perhaps, but that the human contacts change. So we're working with Mandy's team. So Louise is very heavily involved in this in terms of how we then capture that patient experience. And also in terms of customers, well, it is about colleagues. So we'll be looking as well about the number of complaints and concerns that we have raised about how colleagues interact with each other. So we'll be monitoring our grievance processes and informal resolution to issues. So we'll come up with a suite of metrics that we'll try to capture through Mandy's team and through the workforce and OD team. And as John said, report them through the people committee.
Thank you, Lisa. I'm going to ring in Paul and then Ewan and then Maynard.
Thanks, Chair. Yes, Lisa, on page 23 of the report, it highlights that this programme is going to take basically 2.5 years, I think, to work through on a basis of a day-long course. Given the significance of this and the importance of it, query really as to whether we feel that's adequate and sufficient to be able to affect the sort of change that we think is likely to be required. And secondary question, I guess, is whether this programme could be thought was given to whether this programme could be included as part of the induction programme for new staff.
Thanks, Paul. Lisa. I think Lisa may have been frozen.
That's my sheet, but yeah.
She doesn't want to answer your question, so she's standing very still.
Oh, she's back. Come on back.
I got you on page 23 of the.
Oh. Mandy, you're going to try and help. Lisa, you're back, I think.
Oh, Lisa's back. I was just going to jump in and try to help, if I may, because obviously release of staff is key, as Lisa highlighted, and it will be a balancing act of making sure that all the other mandatory training is undertaken, as well as focusing on this training, and in particular linking it into the induction programme. I think we need to get away from sheep dipping our staff into something that's going to be squeezed in between a variety of things that we need to induct people in versus what this programme is aiming to do. And Lisa and I were very fortunate that we had an early taster of it, to make sure that actually we show people a different way of supporting the culture change that we want to bring about, and that is through the investment that we believe that this programme will provide. But Lisa's back, so I think she'll capture now.
Sorry, okay. I've posted a message in the chat bar because I do keep losing my internet, so I lost you after on page 23 of the report. And then I picked you up again about induction, so it will be part of the induction programme. And if you want to either type again the question, sorry, Paul, or if you want to repeat it, I will answer either here or on the chat. I'm really sorry.
So try again.
Yeah, go on.
Yes. Yeah, Lisa, just page 23 of the report, we highlight the fact that it's basically taken 2.5 years, I think, to deliver the programme, and whether that sort of length of time is enough really to be able to achieve the sort of impacts that we're seeking to achieve with this programme. That was the question in a nutshell.
Yeah, okay. We are employing more individuals within our training department to try to roll this programme out faster. What we're trying to also do though is be realistic about that staff release. So we've put that in as a worst case scenario, but we'll be doing our absolute best to roll it out as quickly as we can. without having impact obviously on service. So we'll keep monitoring that through the People Committee, and we do hope to achieve it much quicker than we have anticipated.
Thanks, Lisa. I'm going to bring in Ewan, please. Ewan.
Great, thanks, Chair. Yeah, thanks to Lisa for the report. It was just, whilst it's welcome to see what is being kind of proposed for our colleagues and staff on all the kind of main sites, obviously with what we're seeing now with the strategy in terms of healthier Mid and West Wales, a lot more engagement within our community settings. So will the training and support be extended to those kind of volunteers and kind of community-led organisations who work in partnership with us? So those individuals will also benefit from this training, so that we've got a baseline standard of support for all kind of clients and patients that we come into, regardless of where the setting is.
Absolutely, and Amanda, who is our Head of Education and Development, is on the Regional Working Group, the Regional Workforce Board, and part of that is around what training can we share across each of our organisations. So there would be absolutely no reason why we can't use this. I don't think we particularly need to tailor it either to make sure that we have got that programme across the system. So very possible.
Great. I think it's particularly for our volunteers, because obviously they're not paid staff, so there isn't that kind of thread of commitment, as it were. But I think it's really important to have that baseline. So very much welcome that, Lisa. Thank you.
Yeah.
Thank you very much. I'll bring in Maynard now.
Thanks, Chair. I don't think it's so much of a question as a worry. One of the things that was picked up early on in your report on page 5 were the frustrations with issues over IT systems. And I worry that some of these systems have now been in place quite a long time. And if they're still providing frustration for our staff, then we need to be feeding back to the people who provide the systems that they need improvement to be made fit for purpose. Most IT systems these days tend to be fairly intuitive. Looking at the list of systems there, I don't think many of those could be described as intuitive these days. And as everybody knows, and has been demonstrated this morning, when IT goes wrong, it can be really frustrating.
Thank you. Shall I just pick up on the main workforce system that we have there? So the electronic staff record is the key one in terms of how we report staff, attendance at training programmes, etc. We are about to move into the procurement of a new system. So it's a UK-wide system. Wales is one of the regions that is a main player in that, and we have got members of Hywel on each of those working groups around what we require from a future system to ensure that we don't have the clunky processes that we have now to help us support our staff. So we're very much engaged in making different changes to that system.
That's good news.
Thanks. Hugh, did you want to come in on that point?
Chair, I'm happy to come in. Yeah, and the point that Maynard makes is very well made. I know frustration that many of our frontline users, indeed many of us, face daily. And there are contrasting examples of good practice. The nurse clinical record, I think, has been an example of kind of user-centred design that has really made a difference. And I think what we're talking about here, some of the legacy systems that, as they come up for replacement, that need to make sure that user-centred design is absolutely at the core of the way in which we develop, adapt and implement our systems across the health board. So it's a common issue that I am very conscious from our teams, and it is an impediment to them working, whereas digital should clearly be an enabler.
Thanks, Hugh. Well, if I could just briefly summarise on behalf of all the board members, I think there's a huge thank you to you and the team, Lisa, for taking this work forward. We've had a workshop recently with Michael West on compassionate leadership, and one of the main messages was one of the key roles of a board is to set the culture, and this is one of the tools. We know the challenges. both in measuring the change, and we also know the challenges in releasing people. But thank you so much for taking this work forward. Really, really important. And I think board members should avail themselves of that training as well, if that's possible. Just to learn, you know, again, look after ourselves and look after each other and look after our organisation. So thanks, Lisa. And the board's happy to accept all the recommendations. Diolch. So we now go on to implementing the Healthier Mid and West Wales strategy, the programme business update. Over to you, Lee.
Yeah, thank you, Chair. So board members will, of course, recall that at the last meeting we approved the programme business case in support of our strategy, Healthier Mid and West Wales. And after taking on board some of the comments from board at that time, we submitted it to Welsh Government shortly afterwards, and Appendix 1 has a summary of some of the amendments we made as a result of that. I can update board that we have received some scrutiny comments from Welsh Government since then, and we're in the process of considering those and producing a response, which we'll update board members on in due course. In the meantime, we have progressed towards identifying the site for the proposed new urgent and planned care hospital. Board members will remember that a shortlist of 5 sites were agreed previously following a review workshop in October, of which 2 sites were shortlisted subject to further investigation. A further workshop has since been held in February to confirm the recommended sites to be included within the final shortlist, and I'm pleased to advise that a consensus decision was reached at that workshop. An endorsement of the revised shortlist will be subject to board in committee discussion later today. The paper before you today sets out a proposed methodology to appraise the sites, which we're hoping board will be able to endorse today. We are committed, as board members will know, to transparency and public involvement in this process, and members will note that we have issued invitations to 200 residents and stakeholders who will make up over half of the representation in the shortlist technical appraisal group. I can update the board that we have received 63 positive responses to date from the public. So we're in the process of analysing those responses to ensure we've got balanced representation across all parts of our population. This group will then be asked to weight the agreed criteria for selecting the site, score the shortlisted sites against that weighted criteria, which will then bring forward to board considerations, hopefully in July. The outputs from that process will be an assessment of the clinical implications of siting the new hospital at the east, west or centre of our identified zone, in particular to ensure the long-term viability of key services, and the paper updates on the areas that we're looking at in particular. In addition, we'll be making assessments of the workforce and economic implications of the particular locations, and as I say, all of that will come together for board to make a decision later in the year on the preferred site. Finally, in order to ensure the appropriate specialist support for the site appraisals, I'm also asking for board to approve the appointment of some consultancies via direct award, because this is extremely technical piece of work now as we look in more detail at the 5 sites that we've got. So at that point, Chair, I was going to just open up to any questions or comments on what we put forward today.
Many thanks, Lee. Any questions from members? If I could bring in John, sorry, Judith, Ewan and Maynard.
It's okay, thank you. I think Lee's caught the problem that Lisa's has with his connection, but I think we caught it all, Lee. Yeah, really good update paper. Thank you for all the information. I wanted to ask a question about the work going on around women and children, which you identify in the paper on page 4. The sort of introduction talks about clinical pathways and then talks about hospital configuration and community model for maternity and child health. And I understand the context of what you're wanting to ensure, but I just wondered whether that was going to include a little more work with primary care and also community child health. Because if you're talking about community, then there's nothing in those bullet points that leads me to think that that's going to be part of the discussion. So I'm just looking for some assurance around that, please.
Yes, we do have community child health in that work that's going on at the moment. I guess there's two pieces of work here that we're going to need over the coming months. One is on the pathways and clinical pathways we need to develop across the whole of our system. Develop the outline business cases, which will be the next stage of the business case process. We're going to have to systematically do that for all services, and that will certainly include primary, secondary and community services in the round, and on how we shift that balance of care in line with the strategy and move towards a preventative and community model. The other piece of work that we're doing in parallel with the updates focused on is there are some specific issues, and a narrow set of specific issues that we need to consider in relation to the viability of secondary care services, depending on the location of the hospital. Apologies if my signal is dropping. So this piece of work that we're referring to here is specifically in relation to what understanding the implications of the siting of the hospital on those acute secondary care services. So specifically, we're also looking at obstetrics, midwifery-led care, paediatrics, and then stroke services. So that is additional to the work we're doing. We do need to have that very specific focus on the implications for the secondary care services and the viability of those. So just to reassure you, the pathway we're referring to will be system-wide, but we do need to have a very clear answer in relation to the secondary care implications.
Okay, thank you. I think I caught most of that. Thank you.
Sorry.
Lee, I'm sorry to say that you're breaking up quite a bit, but Andrew wanted to come in on that particular point as well about the child pathway. So I don't know if you want to switch off and come back in, Lee, while Andrew picks up that point, and maybe the reception will be better. Andrew.
Yeah, no, it was just to add and to help in terms of the community child health pathways and community paediatrics to the children and young people group that I chair. We will be setting up a work stream that's going to review our community paediatric service model, and my intention and my ambition that I've set them is that we come back with a view of what that means as part of the medium-term planning for June that will come to the board in June. So that community paediatric pathway element is not going to be lost, Judith, and is sort of being picked up as part of that process as well. So just to give some added assurance that it's not being missed.
Thank you, Andrew.
Thank you. And there's also a message in the sidebar from Alison about, the pathways will need to pick up the entire pathway. Absolutely. And I think we had our GPs with us a couple of years ago, and they want to be part of and help to lead the pathway rather than the design of it, rather than it be imposed upon them by secondary care, and it's not their pathway. So that inclusivity is really important. I'm going to go to Ewan now, then Maynard, Gareth and Michael.
Great, thank you, Chair. Yeah, it's just picking up in terms of Appendix 2, particularly in terms of the fact that we've had 209 members of the public who've asked to be kept informed. And I think, full credit to the team in terms of the transparency of communications which have been promoted throughout the whole process. I think it's more a comment, perhaps an observation, really. I mean, obviously, we saw about 150 people outside Withybush in the last couple of weeks who are genuinely passionate about the services and the retention and, what perhaps the proposals mean for them. But, it does slightly frustrate, I think, many of us in terms of, we provide these opportunities for people to engage, and 209 people have taken up that engagement. But how many of those people who are protesting outside Withybush are actually engaged with us to have that more kind of concerted dialogue, to be part of the process rather than working outside it? But I suppose my kind of main comment is I really do welcome the fact that we are kind of looking at promoting and communicating the wider socioeconomic benefits. And I think for many of our communities, that is something which is being slightly overshadowed by political point scoring, particularly as we see the election process coming up, because the benefits in terms of our skills, supply chain, workforce, the environmental benefits that we're promoting as part of this process are being overshadowed. And I think once we get past May the 5th, I would be really supportive, as I know many would be, in terms of promoting those messages across our communities and that engagement. So I know, Lee, in terms of what yourself and the team are doing to prepare all that information, and I think I really welcome a kind of timetable of events, I suppose, in terms of where we can all kind of work within those communities to really kind of get those messages out there in terms of the sustainable benefits that the wider proposals of our strategy for Mid and West Wales will bring, and not just perhaps focus on the kind of emotive issues which perhaps overshadow the longer term benefits to our well-being, socio and economic based.
Thank you, Lee.
Yeah, so happy to comment on that. So I think we certainly do recognise the wider impact that this has on the population and the concerns that some people will have, and equally the benefits that can bring to businesses and the economy of West Wales. So I think we're in the process of developing a wider communication plan, and certainly bring that back to board and board members for a discussion in due course. But very important that we continue to engage with our public. This is on behalf of our public that we're trying to progress this, and we will obviously look to bring all voices into that, and also bring that additional information that you're referring to, and which can help people see the broader benefits that we can bring to Mid and West Wales.
Thanks, Lee. If I go over to Maynard, please.
Thanks, Chair. I'll follow on from Ewan's first, because I've got two questions. It's just a note in the list, in Appendix 2, the list of areas to get feedback from in terms of young people. It only specifically mentions student unions, and I think we need to be looking further afield than just the student population. We've got means already of engaging with young people out there, wider than the student population. I just think we need to be looking further afield. Main question, however, though, is back in the main paper in terms of the clinical appraisal work streams. The project scope states that an objective assessment of the clinical implications, but there are only 2 clinical areas named as being within scope. I was just wondering why it is just those 2.
Yeah, happy to respond to that, Maynard. So we obviously did a very detailed piece 4 years as part of developing the strategy, which reached the conclusion that the zone that we'd identified, St Clair's through to Narberth, was suitable, if you like, for us to be a new hospital from, and would provide sufficient access to all parts of our geography, given the challenges we've got of rurality, etc. So on that basis, anywhere in that zone is really identified as suitable, if you like, for the new hospital. But at the time, there was acknowledgement that women and children's services in particular, and it's referenced in the paper that there was a board recommendation for, in relation to that, we need some further work because of questions around the long-term viability of those services, depending on the exact location of it. So we just needed to do some further analysis on that. So we've started there, and then we've added stroke into it, because as we've got into this, we've identified the same issues or potential risks still equally applied to stroke services, in particular a hyperacute stroke unit, if we were to provide that within the new hospital. So we haven't excluded anything else in that sense. What we've done is we've identified these as specifically needing attention, and then we our clinicians and across the organisation to advise us as to whether that is correct or not, and whether there are further services that need added into that. To date, no further services have been identified in that category, if you like, of significant viability concerns. So we're not saying we wouldn't expand it to further specialties and services if that they were identified. We would need to do that, but those are the ones with the for.
Great, thanks, Lee.
Just to come in on that, Maynard, I think we caught most of what Lee said, but yeah, so these have been selected on the basis of their sensitivity to the question of precisely where the land might be. And just to add, we did have a discussion at the PVC steering group that I chair about also widening our thinking to think about services that we may wish to provide in the future that we don't currently exist, and whether any of those would fall within the sort of category of geographically sensitive between Narberth and St Clair. So the team are looking at that as well. So it may well be that this list expands, but it isn't the same as the wider piece of work that Lee talked about, which is the building of all of our pathways for all specialties, right from primary care through back into rehab and back into people's homes, as part of the OPC development that will occur alongside this.
Thanks, Steve. And Lee, you do an amazing job with very difficult IT challenges, so I'm sure colleagues will step in, as Steve just did, if we don't get all of what you say. If I can go now, please, to Gareth and Michael.
Thank you, Chair. And yes, Lee's job is difficult enough as it is without the additional IT difficulties as well. So thank you. My question relates again back to building on what Ewan said on Appendix 2, and I totally agree with his comments on the 209 respondents. But particularly if we come to membership of the shortlist appraisal group, my question would be, most of the stakeholders are very well covered, so that's very extensive. The one group, perhaps, with regards to the stakeholders on the health board representation that perhaps is not reflected, in my view, would be, are we satisfied there's sufficient and appropriate input from primary and community care? So I noticed from a public point of view, the 7 localities and the clusters are represented. Logically, I would expect the representation there from the clinical input from the community and those localities as well.
Yes, thank you, Gareth. Agree entirely with you, and that's intended to be captured within the clinical and staff as various grades items. So we're not being specific within that as to whether it's secondary or primary, but we would certainly want primary care involved in it.
Thank you, Lee. I was hoping that was the case. Thank you. Take about. Thank you.
Thank you. If I could bring in Michael and then Winston.
Yeah, thanks, Maria. Thanks, Lee. I thought it was a really good paper. Just shows you how much significant progress we're quietly making in the background on this. So really impressive. I thought it's just worth reminding ourselves that there's a tendency with these sort of huge programme business cases to focus on the building. And rightly so. I think, you know, especially given the impact on the either historical or future impact that new buildings can have on communities. But I think it's also worth reminding ourselves that the size of the prize here isn't necessarily about a new footprint. It's actually about developing the 21st century pathways and clinical services that the people of the community deserve and haven't quite had the ability to achieve just yet. So from that perspective, I think it's the consultation on the building is really important, but I think there is a wider story here. My question really is for Hugh, and I'm just picking up on Lee's comment about the consultancy fees. I just wanted to understand what the relationship between the consultancy costs are and the financial plan that we're going to look at slightly later on in the meeting.
Thank you, Michael. Yes, the consultancy fees themselves aren't included in the financial plan. They will need a risk management strategy around them, and we'll work with Welsh Government on what that looks like. Clearly, we're doing this next piece of work now, pending approval of what's been submitted to government, and need to take a certain degree of risk in so doing, and that's been a discussion that we've had as an executive team around the approach to maintain the momentum that we've developed. So at the moment it is a risk. I'm conscious that it is a non-recurrent risk that we're taking at this stage, and that is therefore manageable in terms of the items identified in section F. In section G, then obviously there would be a recurrent impact there in terms of the ongoing resources that we would need in terms of staffing and internal resources, and that needs to be worked through the exec team again.
Okay, thanks you. Thanks, Lee.
Thank you. Winston?
Thank you, Chairman. Thanks, Lee. I echo IM members' comments that this is a really helpful and really clear report, and that we are making great progress. Certainly, it's a very, very exciting development for Mid and West Wales, and you really do have our support in sort of taking it forward. My question is more builds on Michael's last one, actually, which was in section E about additional appraisals. I noticed the establishment of a workforce appraisal group and a financial economic appraisal group. The costs incurred for consultancy and direct awards, and as he has helpfully mentioned, the resources which may well be implemented, recruited to in relation to making this happen. I guess my overall thing is at the moment we're proceeding at a degree of risk in assuming that this will be approved, and there's no reason why it shouldn't be. But my question is, what sort of support has Welsh Government offered, not just in terms of financial support, but have they offered any support in relation to technical expertise or people that could be seconded to Bwrdd to work with us and our team with this? And if they haven't, have we suggested that they do?
If I pick that up, so we are obviously in close discussion with Welsh Government on this. They have been, through shared services, providing us with technical support throughout the process as part of the land selection and in other ways, and obviously guidance and on some aspects of it. We've not had offers of secondments or individuals to come and work with us as part of that yet, but we will get into discussions with them on the specifics around that over the coming months. There's limited resource, I guess, within Welsh Government to do that, to be frank. So we would need to probably address most of that ourselves, but certainly we will want their input and advice as necessary.
Thank you, Hugh. Thanks very much.
Thank you. Lee, there's a question in the message bar from Devon. Are all the age groups represented on the group of participants? You did say earlier that the responses are being analysed at the moment.
Yeah, so we have sent out letters to all individuals who express an interest. It is skewed by age, I would have to say. So Delph, I think thinking there is correct. So there's a bit of work for us to do to make sure that we've particularly got younger people represented in that workshop. So we're very keen to do that. So we will look to find ways of addressing that and equalising it.
Thank you, Lee. Any other questions at all? Are the board happy to accept the recommendations? And Lee, on behalf of the board, can I thank you? You know, this is a plan to transform the healthcare in West Wales, as you said at the last board meeting, for the next 50 years. And that emphasises why it's important to hear the voice of the young, because they'll be there a lot longer than the rest of us to get the benefits from this health system. And it's, you know, going down the road to the 21st century pathways, which are really important. It's a potential 1.3 billion investment in West Wales, and all the jobs that will bring, all the local jobs for local people. And as we said at the last board, we promise to listen to our clinicians and our public all along the way when we are delivering this whole programme business case. So diolch yn fawr, thank you, and well done on the progress. I think one of the members said it's about quietly going on in the background. It may be quiet, but it's absolutely huge piece of work. So diolch. We'll take the integrated medium-term plan next, and then we'll have a short break. So over to you, Lee, again.
Yes, over to me again. Sorry, hopefully the connection will hold up a bit better now. Okay, so members will be aware from previous updates that the health boards have a responsibility to produce 3-year integrated medium-term plans, something which this health board has never actually been in a position to do up to this point, mainly because of our financial challenges. The requirement to produce an IMTP was suspended through the pandemic, and instead we were asked to produce quarterly and then annual plans. That requirement has now been reinstated for 22-23, but of course we still do remain in a pandemic, and therefore we are operating within a very uncertain planning environment, and I think the plan that you see before you reflects that to some extent. Following receipt of the allocation letter at the end of December, we've taken an assessment of the implications for our financial position, and we have, on the back of that, and amongst other things probably, had to unfortunately conclude that we're not in a position to submit an integrated medium-term plan in the way that we would want to do at this stage, at least. So instead, what we've done is developed a draft 3-year plan with the intention of working towards an IMTP later in the year, as the paper says. The plan itself is very much structured around our strategic objective, sets out the planning objectives and key deliverables within each. It is intentionally shorter and more concise than previous plans, and at around 50 pages, and that reflects the feedback we've had from Welsh Government previously, but it also reflects my own ambition, I guess, to make sure our plans are as accessible as they can be, both to our staff and our population, ideally. The plan naturally spans a long period of time, so it's from today all the way through to 2025. So what it's seeking to do is connect our short-term actions with our longer-term strategic vision. So we are of course a very large and complex organisation operating, as I say, in a highly uncertain period. So what we're not attempting to do is set out a rigid plan and capture all individual actions the organisation is taking. Rather, we're articulating a direction of travel and a method of working to some extent, which will allow us to respond dynamically as the situation develops, whilst also ensuring we're moving forward plan. I obviously have the pleasure of presenting this item on behalf of the executive team, but of course it touches on all aspects of our organisation, so I'm grateful for the contributions of all our respective teams, particularly as this, as we noted earlier, has been produced over one of the busiest and most challenging periods in memory. So I think we recognised with the plan that there is further work to do, particularly to reach a balanced financial plan, but also across a number of our priority areas. But hopefully it does set out where we are at this point, provides a direction of travel, as I say, and sets the foundations for an IMTP for later in the year. So I was going to pause at that point, Chair, if that's okay, and I was going to I think you would like to come in and add some comments on the finances. So before opening to questions, if you're okay with that, Chair, I was going to invite Hugh.
Thanks, Lee. If I bring in Hugh.
Thank you, Chair. And just to pick up where Lee left off to a certain extent and take you into the finances. Clearly, we are presenting here a deficit plan, and by definition that requires an accountable officer letter to be written from the Chief Executive to Welsh Government to outline the rationale for the deficit plan and the actions that we propose to take as a result of that, and that letter has been drafted and will be submitted today. In terms of the plan itself, it's been developed in 3 chunks from a financial perspective and aligned with colleagues. And there is a core plan, and there are 2 extraordinary elements then as additionalities to that core plan. If I come on to the extraordinary elements first, and then I'll come back to the core plan and the bulk of what we're talking about today. First extraordinary element clearly is our continuing COVID response, and there are 2 elements within that: our programme response, particularly picking things up like vaccination programme and PPE testing and tracing, and that comes to 16.3 million in terms of anticipation for next year, and transitional costs, which represent our costs within the Health Board, of 27.8 million. So a significant amount within the plan does relate to continued COVID response. The next item then is our exceptional pressures that we're seeing going into next year, and there are three chunks to that. The first one being energy. We've anticipated in here 10.7 million of additional energy costs coming through to us. The outturn may well be more significant than that, and that's clearly a key corporate risk to us now that we are managing alongside colleagues in government and shared services in the way in which we purchase our energy and utilities throughout the year. The next element then is the national insurance contributions for the health and social care levy, and that's at 3.1 million for us, and then the real living wage at 3 million. So again, some very significant extraordinary cost pressures that we're seeing and inflationary pressures that we're seeing in the system. And the third element then is the core plan that we're looking at, and the plan itself has a 25 million deficit as part of our assumption, but that is predicated on delivering 29.3 million pounds worth of savings. Now, we've already heard about some of the system challenges we are facing at this point in time and some of the uncertainty that we're managing within. So that is a very significant savings requirement that we would need to deliver a core plan that remains at 25 million. At this point in time, while we've identified opportunities, the challenge for us over the next few months as we get into submitting an IMTP is to work up what our target operating model is as a result of that, and what the requirement is across the system to embed that saving within our budgets. But at this point in time, we don't have assurance that those savings have been developed to a sufficient level. Therefore, the core plan in terms of a forecast for the year as an outturn, I would say is somewhere around 42 million. So while the plan is 25 million, my forecast at this point in time is around 42 million. That's a very significant issue for us to address and deal with, and that's something that I know colleagues around the exec team are very focused on. Chair, with that, I'll hand back to Lee or open to discussions.
Thank you, Hugh. Lee, do you want to add any more, or should we go to the discussions?
No, nothing further, Chair. Thank you.
Thank you. Open for questions, please, and comments. And I just want to thank you for setting out so clearly a huge challenge. Judith, a point of clarification on the financial plan.
Yeah, thank you. And I'd certainly like to echo your comments on the actual plan. It's really well set off, and such a pleasure to see something so succinct in the way it's covered. It's a very specific question, and I may have misread it, but on page 50, there's a comment about energy to say that it has not been possible for the sourcing team to procure any gas for April 2022 onwards. Is that right, or am I reading it wrong?
Sure. Just in response, there is quite a complex process to manage the risk of energy costs in any year, and there is a balance of buying energy on spot markets on a daily basis and buying energy on forward markets where you manage that risk of cost pressures in the future. What the point is alluding to there, and apologies if it's not clear, is that we haven't been in a position to buy and manage our risk on the forward markets for next year because of the volatility that we're seeing, and therefore the risk is something that we will have to manage, and it is being managed on not just a daily basis, but actually it's an hourly basis. You know, it does fluctuate significantly, and the point therefore is that we've not been able to cap that risk at this point in time.
So we're not going to run out of gas, to be very simplistic.
We're not going to run out of gas, but it may cost a premium to get it.
Yeah, apology for the very simplistic question, but I just wanted to make sure. Thank you.
Useful assurance.
Really important. If I could bring in Winston and then Michael, please.
Yeah, thank you, Chair. Thank you, Lee and Hugh, for putting this together. I don't underestimate how incredibly difficult this has been and continues to be by trying to connect all the dots together. I like the fact that you'd set it out in relation to what the core plan is, COVID-19 and the exceptional items. Could I ask whether or not we just look at other exceptional items such as demand and recovery? Because I do think that the growth in those patients in the areas that I think you refer to these later on in this board agenda in your integrated performance report on where those key pressures are going to be, and they seem to be sort of rising demand and how we recover that. I kind of almost hint that that may be also an exceptional item. I know it relates to the core plan, but I think it's exceptional that we've had that growth in the numbers of patients waiting for treatment over the period of time. My specific questions is that we've really focused in here about the year of 22-23, and I think we ought to be almost looking at this on more of a longer term basis, because I think here you've said to actually achieve £29 million savings in 1 year is going to be an awful challenge. But maybe if we're looking at what are we going to be achieving over the next 3 years, then that may be more of a it might be more of an achievable thing to do, or maybe more of an achievable thing for people to think about, rather than looking at what we're going to save tomorrow, but thinking what changes can we make over the next 3 years, and maybe a more easier way for people to engage and understand the scale of what we need to do. And finally, my other observation is, which is in the concluding remarks, which I think is absolutely right, is that we're going to need to redesign our services, and we need to really look at looking at our certainly redesign of our urgent and emergency care systems, and support our workforce as well, because with delivering all of this, we're going to need the right people in the right places doing the right things.
Winston, Hugh.
Yeah, if I round up the response to hopefully cover all three, the way in which I've assessed our extraordinary cost pressures is very much on the supply side. So those are pressures that are coming through from cost pressures externally driven largely, and challenges on the supply side, and I think reasonably packaged therefore as extraordinary in that sense. The demand side challenge we have, which are clearly significant as well, I've not packaged them in that way, because I think it's for us to respond to that as part of our target operating model discussions, as part of our long-term strategy. These are issues that are inherent within our communities, and therefore we need to think about how we address them. And likewise, configuration costs and challenges that we have. In terms of the savings challenge that you allude to, and yes, it's a challenge that we're going to have to think about over a period, working through that very much with the executive team now to understand what can be done when, and which schemes can be accelerated and which need time to be implemented and embedded. But I'm also very mindful that I want to make sure that anything that is expressed in financial terms represents the direction of travel that this organisation is committed to, strategically, operationally, and in terms of delivering quality and safety and the outcomes that our communities need and deserve. So I don't want this organisation to look at its financial challenge on its own. I want us to look at this as a collective endeavour to develop the operating model that we need to best serve our communities.
And there was another point, I think I was talking about the workforce side of things, in a sense, and how important that is, because that forms about 70% of our costs.
And indeed, I do apologise, Winston, because I think as part of developing a target operating model, clearly our workforce is going to be crucial in delivering what we collectively then ask of them.
Thank you, Hugh.
Thank you, Winston. Michael.
Thanks, Maria. My question was about their planning objectives, really. I just wanted to recognise that actually they've moved on quite a pace over the last couple of months since we saw a first iteration of this. They look, not trying to promote Steve at all, but I noticed that it's from a reflection of the chief exec's kind of involvement. They look crisper, they look more cohesive, and I think it's also worth reflecting on the fact that they're a reflection of the fact that the executive aren't just focusing on today and today's issues. There is still a huge amount of energy and engagement being focused onto the medium to long term, which I think is absolutely right. I suppose my reflection and question would be, but there's an awful lot of them. So some reassurance that there's enough bandwidth in the executive team and the wider organisation in order to successfully transact them all would be quite helpful, I think.
Michael, I'm going to bring in Steve.
Yeah, thank you. I think on that point, Michael, but actually on a couple of the other points as well, I think I could pull some of this together. But yeah, thank you for the feedback on the POs. I've now met with every exec and signed off their planning objectives, and as you said, we debated in that process exactly what they were going to be doing and sort of crispness of it. So thank you. It's good to see that feedback. A few more tweaks to do, having read it again, but you know we have got a bit of time to do that now in Q1. I just wanted to set out because I think it answers your just where you sort of ended, Michael, but also some of the questions raised by Winston and others. The process we're going through now in Q1, largely to try and see whether we can land this plan. So here, as we know, and the finance team did a really good job coming up with a set of opportunities which were far in excess of what we needed to deliver 25. However, included a lot of assumptions, a lot of hope, and some really very significant changes for us. At the moment, the team is going through translating that into the service changes, as Hugh described, the sort of target operating model approach that we're taking. So we stop talking about savings and we start talking about what we're trying to deliver in terms of the services for our population. And that will link the second part of that, the second leg of that stool, is that will then link to Lisa's work around the staffing model, which has come on in leaps and bounds. And as you know, we are now offering that expertise and that approach for the whole of Wales, and that was discussed at the chief execs meeting that I chaired last week, and we'll be going to the leadership board for NHS Wales shortly. Those things coming together will come up with a plan which will either be, which is aiming to get us to 25 million this year, but actually the most important part of it is that it's a deliverable plan. I think reflecting back on discussions we've had previously, and I think some of your reflections previously as well, Michael, what we need to do is look in the eyes of the plan and say we can deliver it. Now my hope is, whether it's 25 or some other figure, that by working really closely with Welsh Government alongside all of this process going on internally, that they will see the deliverability of that plan regardless of the number and still be able to support our roadmap to recovery, which might start with a high figure potentially, but still get us to where we said we'd get over the medium term. And that will therefore allow us to have a signed off IMTP as part of this process, which is sort of the prize. But in some ways, I want a plan first that's deliverable and that we know we can deliver, and then move on with that. There's kind of, once that's come together, the finance target operating model to staffing requirement to what that means for our overall financial position, is the exec team needs to build a bit of time in, and we talked about this yesterday before it comes to board, to take a step back from it all and say, right, can we really do all of this? Because it's all come together as a set of spinning plates. So I would agree with you. We do need to just assess whether we're being overly ambitious in the scale and scope of what we're trying to do. However, I'm sort of optimistic that we're still up for it, if not in its entirety, then in the vast majority of these things. And I think it's demonstrated by the feedback we had from last year on our recovery plan from Welsh Government in particular. It was very ambitious, but for most of our planning objectives, we're on track to deliver it, not all, and that ambition proved to be right. So we've got to get the balance right, but we need a bit of time at the end of all of that quite complex technical stuff as an exec team to take a step back, so we can reassure you or assure you at the board meeting that we got something which we think is reasonably deliverable, but it's going to be a push, because I think that's right.
Yeah, thank you, Steve. Thank you. That does give assurance, and that balance between ambition and deliverability is really a challenge, but taking that time out and working all together, and on the basis of what's already been achieved over the last couple of years, I'm really optimistic as well. So I'm just going to ask the board, are they happy to approve the recommendations? Yeah, thank you very much. And so now we'll have a 10-minute comfort break and resume at 11:42. Thank you, Diolch. Well done, Steve. Yes. Thank you. Welcome back, everybody. If we go straight on to the operational update and progress report, over to Steve.
Yeah, thank you, Chair. I'll just be relatively brief. The paper is largely self-explanatory, but I did want to focus a little bit on the challenges we face, but we continue to face. Firstly, just to recognise, as I do in the paper, that we did pass an important milestone, 2 years since the first national lockdown a week or so ago. And just wanted to recognise in all of that, as we have many times at board, the remarkable efforts, the sacrifice, and indeed some of the loss for our staff and our local population. It has been a tumultuous 2 years for us all, and we're very pleased to hold a ceremony recently using our Facebook process, and thanks to Alwena and the team for setting that up. Now, I know it wasn't easy. As we've kind of alluded to in other parts of the meeting, the pandemic has absolutely not gone away, nor has the wider consequences of what's happened over the last 2 years, both for our staff and our public. We know our staff are tired, some of them are exhausted, and there are very long waits for our services, and it does feel like the road to recovery is long, stretching ahead of us. However, good to see, picking up our discussion just before we went on the break, our programme business case and our IMTP giving a real sense of hope that we are going to be able to move forward from this. Our rates in the community related to COVID have been rising since I wrote the report. Again, really disconcerting to see that. They stand at around 450 per 100,000 now, and the positivity rate very high at 38%. As I say in the report, just draw your attention to the fact that these rates are probably underreported given the changes to the testing regime back in January. Indeed, local estimates might put it at almost double, if not more than double, the amount that's actually being reported through the Public Health Wales system. But I've left the numbers in my report as is because relatively they do show the trends, even if the absolute numbers are underestimated. But it does appear at the moment more positively that having risen quite a lot, those rates are now starting to stabilise a little more and may start to come down over the coming days. However, we should have in mind the changes to the testing regime, which I'll ask Alison to update on shortly, will mean that this data becomes less and less reliable as we move forward. But we are, as a result of those increases in rates and indeed the wider impacts of COVID over the last 2 years and the increases in demand, seeing just unrelenting pressure on our services, indeed some extreme pressure at times. And I know Andrew will be keen to update the board on events, particularly in the last week, which are not isolated across Wales, or indeed we haven't got close to this before, but we did last night in a very rare circumstance, call BGH, Bwrdd Hospital. We raised to the very highest level of escalation for a number of hours overnight. So that's a level 5, which you rarely see. Andrew will want to say more about this. I don't want to steal his thunder, but just to call out that the staff at Bwrdd were absolutely magnificent last night in rallying around, and they were only therefore escalated for a few hours and find themselves in a better position this morning. But clearly there will be ongoing impacts from that, both the staff involved and how tired they were moving into this, and also for our planned care recovery in that area, which we will need to consider in the coming days. But again, proves the resilience, perseverance of our staff, that they did such a good job in such a difficult moment. And of course, for the rest of our hospitals, whilst they weren't at that level of escalation, they have also been very deeply in level 4, I would say, for the last few weeks. Really, they're coming together with 3 things. The rise in the COVID rates themselves leading to higher hospitalisations. So our rate in hospital, this was on Tuesday, so there'd be an updated figure now, around 128 people in our hospital beds with COVID at that point that was suspected, confirmed, and included those in ICU. The vast majority of those are incidental findings or are not those requiring active treatment. Actually, I don't have the numbers for us, but across the whole of Wales, to give you a sense of that, in the first waves of the pandemic, 80 to 90% of people in our hospital beds with COVID required active treatment. Over the winter of 2021-22, the last winter, that fell to 40% as we were feeling the impact of the vaccination programme. It's now standing across Wales at about 12%. So it is heartening to see that. But of course, with those many people in our hospital beds it does cause us all sorts of operational pressures. The second issue, which of course relates to the level of infections in our community, is the number of staff sickness absence we're seeing, the rate of that. And we have seen that creeping up over the last month or so. The latest figure I had, and Lisa may have something higher than this now, or more up to date, was on the 29th of March, which was we were back at 6.4%. So having gone down below 5%, that clearly adds additional pressure to those people who are in. And then, of course, we've got, as we've alluded to a couple of times, significant challenges around flow, and particularly people awaiting some kind of care package, whether that's NHS or local authority provided. The numbers yesterday that we went through as a team in our afternoon update, we had almost 390 people waiting, about 50 of those in hospital, the rest in community, but clearly the community ones are just as important because we run the risk of them needing to be admitted because of some acute event, but also because the whole system is then quite good. So it does remain on our mind that the importance of the workshop and the working very closely with our local authority partners to find a sustainable long-term solution coming out of the back of the work we did this year around the bridging service. Just a few other things. Just to mention on our vaccination programme, we've now done about 865,000 vaccinations. About 250,000 of those were thirds and boosters, and I'll ask Alison to give an update on where we are with the 5 to 11-year-old programme, the spring booster, and our thoughts at the moment in conjunction with Welsh Government thinking around the autumn plan for vaccination. Finally, two things. We've got a detailed paper in there. Thank you to Alison and the team around long COVID, which I hope helps to show where we are with that, and as an emerging and growing issue, I think, for us. And also, I just wanted to pay testament to all the testing staff who have worked in our testing centres across Hywel Dda as part of the UK response. Alison and I had the opportunity to thank as many of them as we could get together last Friday. These are staff who work for Sodexo and Guardwatch, who have been at the core of our delivery of keeping our population safe, and we wanted to pay testament to everything that they've done. We have taken their names and contact details and are encouraging them to keep in touch with us if they do need jobs going forward, and we have relevant positions for them. We want to ensure that we look after them as best we can in this time for them, which must be quite difficult. So with that, I'm happy to take any comments, but perhaps if we could bring Andrew in on the operational and Alison in on those issues I mentioned.
Thank you. Alison, I'll bring you first and then Andrew, because you're already on the screen.
Okay, thank you, Chair, and thanks, Steve. Yeah, just a quick update with from a testing perspective. So today is actually the last day that there will be any public PCR testing across Wales. So the MTUs and the showground has already closed earlier in the week, but the mobile testing units, it's their last day today. So there is a shift now from tomorrow that the public won't have access to PCR testing, but if they have symptoms, they will be able to get lateral flow device tests from the UK portal. The use of lateral flow tests for the general public for just routine testing and the Flow Before You Go campaign stops today. But that, just to give some assurance, the Health Board will still continue to provide testing through our community testing units, the Health Board delivered ones. For health and social care staff that have symptoms, we will still be testing those, and any patients pre-operatively or pre-procedure. So that testing element is staying, so our staff are staying. And Steve's answered the question of Judith there. We did take the names of the staff in Sodexo and Guardwatch, that if they're interested in any roles, that we've got their contact details and we can keep them in the loop. So happy to answer any questions if there are any around those changes to testing. What I've also put in the sidebar is that Steve's right in his report about the published COVID figures, but Public Health Wales are still only publishing the numbers of tests that are being undertaken via PCR. In reality, when we add the LFD positive results in, the current rates in the community are more like 1,300 per 100,000. What we'll see happen to that over the next week, we can't really predict, because the general public testing is going. They will have the option to do LFDs, but whether or not people will access that route, we don't know. So I think the data over the next few weeks is going to become more and more difficult to interpret. So we are looking at what other information we can triangulate to give us a more accurate picture of what the COVID rates are circulating in the community. We have got information like wastewater information and the ONS data, so we will be triangulating some of that. So happy to take any questions if anybody has any.
Thanks, Alison. Anybody got any questions on testing? Well, thank you. If you go on to vaccination, please.
Yeah, so vaccination. So the childhood vaccination, as Steve has mentioned, is underway. The uptake is quite low, but it's low across Wales. And the agreed approach to this was more of an offer rather than a push on this age group, because of the balance of the risk and the benefits, but also the sort of concerns around this age group. But we are continuing to provide that. The spring booster delivery is underway. Again, there are some technical issues from a national reporting, the system reporting methodology, but we have found a workaround for that. So that work is underway, and the team are currently working through the plans for what the autumn booster programme may be.
Alison, in relation to the children's programme, are we providing the vaccinations in child-friendly premises?
Yeah, there's been a review of the premises, and the teams have also been working with one of the pet therapy charities. So we've got pet therapy dogs also on site, and they've been using things like running Disney videos and things in the background. So they're doing the best that they can to make those sites as child-friendly as possible.
And the workforce is experienced with paediatrics?
Yes, yes.
And you were going to talk about the autumn plan as well.
So I haven't got the details of the autumn plan at the moment because it's still being worked through, but I'm happy to either share that offline when that comes through, possibly rather than wait for the next public board.
Thanks, Alison. Any questions on vaccinations? No, well, thanks so much, and also thank you for taking the time out to thank the workforce who've undertaken the testing regime in all sorts of weathers, in the open air, etc. And I know they're not our employees, but thank you very much for thanking them, and hopefully we'll recruit in the future. So well done. Thanks. Andrew, would you like to come in relation to the current pressures?
Yeah, thank you, Chair, and thank you, Steve. You've probably covered and given a really good introduction of a lot of what I would need to say, which is really helpful. So I think I wanted just to start by saying thank you and commending all of our staff for the way that they continue to go way beyond what would be expected of them normally to respond to what feels like a very relentless pressure at the moment in terms of demand on our unscheduled care services and across the system. So that's primary care community and in our front door areas at hospital, and across social care as well, in terms of some of the discharge challenges we're seeing. As a result of those pressures yesterday, as Steve indicated, and after a very thorough review of the risk across Hywel Dda, but also specifically to the individual sites, we felt that we were left with no option really but to take the decision, which is quite rare, to escalate to a level of black alert internally, which was in response to the fact that at that point at 5:30 we had a full ED department. Our staffing position was very challenged. We had 2 ambulances outside, and we had no available bed capacity into which to admit patients. And our big concern was not just for the safety that we were managing and the risk we were balancing on the site at that moment in time, but also the risk to patients in the community that might have needed an ambulance response, and our ability to have been able to immediately release a vehicle from outside our emergency department to respond to such a request. I have to say that on having made that decision, as Steve indicated, the response of staff at all levels on the site has been was actually truly magnificent, and by 10:30 we were in a position whereby, with a lot of additional support from senior decision makers and consultants, and staff coming in to help provide some additional capacity that we wouldn't have been able to open without that response. We were in a position whereby we'd cleared space in the emergency department, we'd admitted a number of the patients that were in the department awaiting beds into beds within the hospital, and we'd cleared the ambulances from outside the front door, and put ourselves in a much better position with space to be able to accept further patients going through the evening and night. So at 10:30 we took the decision that we could de-escalate, therefore, back to still a very high level of escalation at Red 20, but it did signify the fact that the escalation and associated actions had worked, and had worked very quickly. So I'd like to thank in particular Steve as the team at Bwrdd for that response, and would give a special mention to Matthew Willis, Annette Snell, Dawn Jones and David Harrison in particular yesterday, who were responsible for leading the site and developing that action plan and putting together that response. They displayed some really excellent leadership in the face of some really difficult pressure. That pressure we've seen in a sustained way across Haldar and the region, and Jill and I joined a meeting yesterday lunchtime with our senior clinical leaders and our senior operational management teams to discuss that position. I think it's fair to say that there is certainly a growing anxiety and concern about the harm and potential poor outcomes that we may be delivering on the back of some of the delays in access that we're seeing. We're not alone in that in Haldar. That will be replicated across the whole of Wales, but it is certainly an anxiety that was coming through quite strongly yesterday from our clinical leads. And we are doing, from a health board perspective, I think we are doing everything we can to try and alleviate some of that pressure, and there are some really positive signs from some of the analysis Lightfoot have provided us in terms of our front door models, the reduction we're seeing in conveyances, the reduction in admissions we're seeing, and the ability to turn people around in 72 hours at the front door is all significantly improving. One clinician has likened it to me, though, as a bucket, with an analogy of a bucket and a tap, and whilst we can slow the flow of water out the tap, we can't completely turn it off, because we'll always have a degree of demand, and so once the bucket is full, it will inevitably overflow and flood the surrounding area if we can't get some kind of release elsewhere in the system. So I know there's the morale of some of those staff at the front door, with their efforts they're putting forward in terms of turning patients around, is becoming really challenged by some of the wider system pressures we're seeing. And I know that I know they will have listened intently to the start of the meeting today and some of the discussion we had earlier around the steps we were taking to work with our partners across the Haldar region to find solutions to some of those discharge challenges that we are seeing, because I think that'll help provide some encouragement and support to continue with the good actions and good work they are doing, but feel is being mitigated somewhat by that challenge. I should add as well, a significant positive, I guess, in the last month is the fact that we've also restarted elective work on all 4 sites. And there is a very clear strength of feeling again amongst our clinical body that we want to protect that capacity as much as we can. We recognise the impact not being able to provide elective care in the way we would want over the last 2 years has impacted on the population, the community, and in the numbers waiting and the length of wait. And so there is a real steadfast commitment to try and protect that capacity as far as we can, which with the ring fence we've got around it because of the management still of COVID within the community and the system, means we do lose some of the flexibility we might have seen in previous years in managing our unscheduled care capacity, and particularly some of our surgical demand. So, but the fact that we're maintaining that activity is a positive, as I say, but we'll continue to put pressure on the system without some of the other actions that we've talked about today really taking hold. As an update, we're today, as of this morning, we've got just over 100 COVID positive cases across the health board, so it's a slight improvement on where we were earlier in the week, but still reflects a difficult operational challenge in managing the available capacity. So I'll pause there, and I'm happy to take any questions.
Andrew, thank you. That was an excellent summary of the reality of the situation that you and the team and all our staff are facing. The analogy from the clinician about the bucket, I think I'd translate that into a bath. It's getting that plug out the bath, isn't it? And you just reinforce, and I've heard it personally from clinicians, the impact on morale. And it's great to hear the front door is improving, a lot of hard work, and they're so proud of that. But when they see patients who are in hospital who shouldn't be, and the risk to those patients and to the risk to the patients who can't come in, either out in their own homes or at the front door, is so worrying and demoralising. And I did ask Al Wenner, and this is going to happen, that when we do have these meetings, and Steve's doing a lot of background work with the leaders directly, because we've got to get leadership buy-in all together, that the voice of the clinicians is heard and they will be recorded, because they actually sincerely feel the impact on our patients and on all, because of that plug not being able to let enough of that water out, as you said it. But on behalf of the board, I think we should send letters of thanks. Actually, I know it was bronchitis last night, but I'm sure there are other areas for the, particularly after the end of these last 2 years, for the continuing dedication. And it's even harder when the public don't know that's the pressure on our system. And we need to get some comms out about that as well, I would say, because we haven't recovered from COVID. It's probably the hardest part for us at the moment. Jill, please come in.
Thank you, Chair. Thank you. Sorry, just trying to get my camera on. I just want to stand by Andrew actually and support what he said, to extend our thanks to the clinicians, but also just to echo to the board. It was a very, very emotional meeting yesterday. Clinicians were raising their absolute concerns in terms of that potential harm. People felt very emotional and very challenged, as you've reflected, Chair. But we were also asking for that sense of leadership in terms of people being able to step up in these very, very difficult circumstances, but also the challenge to us as an exec team in terms of those things that we could do also in terms of externalising some of this issue, getting that communication out to our public, and also informing Welsh Government and others. But I think what it emphasised really in terms of that backdoor was the importance of what we talked about earlier on in the board meeting, and the need to look at our strategy, both in terms of that sustainable model, learning from elsewhere in terms of what we can do, and working with our partners to be able to take those actions to build that community opportunity, looking with care home providers about releasing the beds that we have available, but also what we can do in terms of the short term. Sometimes those short-term actions, as we've said and seen, don't deliver that long-term solution, and it's going to have to be that creative balance in terms of the actions that we take now that we hope will be able to build on a model for the future. And we've been looking at some of the examples that you alerted us to in terms of Northumbria and Essex to see what they're putting in place, but also very much today asking our partners again to work with us to try to identify solutions. And already we're getting some feedback that they'll be talking to brokers, talking to providers to see if we can extend the number of placements that we've got available. We're also right-sizing packages as we speak to ensure that capacity is used to its best effect. So just wanted to thank everybody again, but to stand with Andrew in terms of just reflecting back the enormous pressures that people were expressing to us yesterday, but also responding then with the leadership that we've seen coming through the system. So just wanted to add that. Thank you.
Many thanks, Jill. It's really helpful.
Just one final comment, and then just an action I'm happy to take forward. But just you mentioned, Chair, comms to our population about what we're facing. I think the communication team yesterday did a really great job. In fact, I think via Andrew, we heard staff were really appreciative of the messages that went out to the public to be with us and help us and understand where we are. So thanks to our winner and the team for all of that. And on the point around thanking those staff, I was planning to drop a note to the 4 people that Andrew had mentioned. I'm very happy to do that on both of our behalves today.
That's great, thanks. And thanks, Alwena. And thank you for that as well, the clinicians video. Thank you. Are there any other updates from exec colleagues on your report, Steve? Or that's fine. Any other questions at all?
Just to mention, from next month or next board meeting, rather, we're going to move to an operational update coming out of Andrew and Jill's operational group meeting, and these reports will be stood down, but it'll still have all the detail that we need.
That's excellent. Thank you very much. Thanks everybody. You know, words can't convey how grateful we all are to all of you and to everybody out there. As when we had the two-year 1 minute silence again, which was designed by our incredible comms team, it was something that our chaplain Irel said. These aren't jobs in the NHS, these are vocations, and only people with a vocation can give as much as everyone's given. So thank you so much, and we'll do everything we can to support everyone, including pulling that plug out as far as we can. So thank you. So the next item on the agenda is the mental health and learning disability progress update. So I can go over to you, Andrew.
Yes, thank you, Chair. And I think I'm joined somewhere for the conversation or to be part of the discussion if needed by some of the senior mental health management team. So I think I've got with Dr. Warren Lloyd, Sava Rees and Kay Isaac, who's attended on behalf of Liz Carroll because she's on leave this week. Liz being the Director of Mental Health, Sava Rees being the Assistant Nursing Director for Mental Health, and Warren being the Associate Medical Director for Mental Health. So I wanted, if I could just say a few words about the paper, but I'm happy to move on to questions because I know this is an area of significant interest for the board and has been. Mental health services have been, and learning disability services have been over recent months in particular. So just to clarify that the paper provides an update against planning objective 5G, which is one allocated to me that covers effectively 3 issues. One is the implementation of transforming mental health services. The second is the development of a strategy for learning disabilities services in the medium term. And thirdly, a transformation plan for specialist CAMS and CAM services across the health board. It's probably worth me reminding everyone, given that I know the members and membership and face changes around the table have been quite significant since transforming mental health was first consulted upon and signed off, and we embarked on our implementation journey, that TMH as a programme really focused on adult mental health services only, and it was very defined in its scope. In doing that, I should probably also apologise, because what I should have recognised in pulling together the paper is that because of that change in membership, it would have been helpful to have had a more clear tie-in in the paper back to what those original TMH recommendations actually were, so you could more clearly track and overtly track the actions that we have taken, the paper describes, and how they relate back to the recommendations. It's fair to say that the action that has been taken by the Directorate over this time, as I've reported before, which was in many ways the onset of the COVID pandemic, helped accelerate implementation of TMH. Those actions describe effectively that from a service model and change perspective, we've implemented the original strategy that came to board 3 or 4 years ago that was signed off for implementation. So they do represent good progress, but I'll find a way, if it's helpful, to better present that back, that links it back into the recommendations for members, so they've got that more clearly. The one outstanding issue from the original TMH piece of implementation programme is the programme business case, which was around the reprovision of some of the inpatient facilities. And our view on that has changed somewhat over the last couple of years whilst we've been implementing the service changes, not least because the PBC we talked about earlier on in the meeting will deliver a significant element of the inpatient provision that we were originally looking to run through a separate mental health programme business case. So we are working at the moment with Welsh Government and with the service to assess, given we know we have wider accommodation issues across the mental health service provision, we're working through how we might reshape that programme business case for mental health to cover the broader accommodation issues we know we've got in the service, not just the adult mental health ones, which largely now, as I say, will significantly be addressed as part of the Healthier Mid and West Wales programme business case. We continue to see a significant challenge for the service in terms of recruitment, in particular, and it's fair to say that the further west you go in Wales, the more difficult the recruitment challenge becomes for mental health and learning disability services, and that plays itself out in our health board region as well. So we still continue to see difficulty and recruitment challenges when we're looking to recruit to Pembroke services in Pembrokeshire and Ceredigion. And that is an underlying challenge for the service as we go forward. I'm conscious that a significant area of concern for the board has been some of the access and waiting times position and the ability or our ability to be able to see obvious and clear improvements in the trajectory of delivery. The directorate, I know, have been working on strengthening their management of the waiting list position, both through some recruitment to some key posts with specific skills and knowledge around this area of delivery, but also in terms of just their approach to waiting list management. We've helpfully had some work done as well by the performance team under Hugh's direction, providing a bit of a deep dive into our mental health service position and providing some benchmarking information across the rest of Wales. And I've discussed with Hugh, and I know the directorate are supportive, but I've discussed with Hugh that as part of our commencing in earnest, if you like, our Improving Together programme, that perhaps we take this area of mental health in particular as an opportunity to run a work stream through that Improving Together programme to enable us to wrap the right support around the directorate to help really drive the improvement programme we need around improving access to those services. Just two more quick points then that I wanted to make. The other being that from an LD strategy perspective, work has been progressing, as the paper outlines, in developing what the future of learning disability services might look like. We're also mindful that nationally there's been a consultation on a policy document by Welsh Government called Improving Care, Improving Lives, which is due for publication imminently. I don't think it has quite been published yet. I haven't seen it land in my inbox as a fully published policy document yet, but we're potentially expecting that ahead of the elections that are due shortly. And obviously our plan as we take that forward our thinking already aligns with that policy document, but our plan will certainly make sure we respond to the direction of travel that sets out. And lastly, I just wanted to emphasise, in terms of monitoring progress of this planning objective, we take the updates through our operational planning and delivery programme group meeting that me and Jill lead. Obviously in the last few months that has been a little bit diverted in its attention towards the immediate response to the operational pressures and Omicron in particular, but as we move into April, I know Jill and I are keen to get back into making sure we're bringing through on a regular basis our updates against the respective planning objectives that Jill and I are responsible for in our two portfolios. So I'll pause there, and as I say, I have got some of the mental health team here who may help with some of the questions if there's some specifics but I just thought it was helpful for them to be present for the discussion and the debate too with the board this morning. It's not quite. Oh, it is this afternoon.
Thank you, Andrew, and can I say a warm welcome to the team for joining us, particularly to answer any specific questions. I'm going to open it to members, please. Gareth, do you want to come in with your question?
Thank you. I will try. I'm having a Lee problem with my internet connection. So if I get dropped out, the question is in the chat bar, and it's in regards to the adverse effects of COVID to our young children, young people population. But I just want an update really on the School in Reach programme and what steps as a health board are we taking to address the specific needs of children, young people, be they home educated or not involved within the educational system? Thanks.
And I know we continue to work closely with our schools and education providers and have been making some good progress in terms of some of the in-reach models that we've got in place. I don't know whether it would be a good moment for Sarah Warren to come in and maybe to provide a bit of an update in terms of where we are with that. There they are.
Afternoon. Thank you, Della, for that question, and thank you, Andrew, for setting the scene. And thank you for inviting us to the session of the board meeting this afternoon. Of course, our children and young people are very important in terms of looking in terms of how we best support them in considering the impact of COVID, and mental health services are one of many services in terms of supporting children and young people in our communities, with the emphasis on trying to support resilience and to normalise the experiences they've had and continue to have, but also in terms of responding to those children and people with acute presentations that require specialist mental health services. So in terms of the School in Reach programme, the board may be aware that we've been part of a School in Reach pilot in Ceredigion, and the results of that has been very encouraging. And Welsh Government has provided further funding to extend the School in Reach programme across the 3 counties. So we, with consultation with our local authority colleagues in education, are progressing that School in Reach programme for both Carmarthenshire and Pembrokeshire. Within that, of course, there's the recruitment opportunities and challenges, as Andrew already referenced, especially in terms of Pembrokeshire, and we are hopeful to start phase 1 of the School in Reach programme in Carmarthenshire and Pembrokeshire by September, and that's based on terms of recruitment and the work we need to do within those 2 counties. Of course, the School in Reach programme in Ceredigion will continue as that's now well established, but it's just making sure there's equity across the 3 locality areas, and working with our local authority and education colleagues in terms of the outreach for those children and young people that's not within the education setting and maybe home educated. But of course, that would be a challenge across the board in terms of those children and young people. But access to our services would be open to wherever a young person may be in terms of if they present in crisis or they need access to our more specialist services.
Yeah. John and then Judith.
Thank you, Chair. Thank you for the paper, which certainly provides the board with an outline of some of the interventions that you're putting in place. And if I can refer to some of them, so for example, on page 5, we talk about the increase in staff with regards to specialist child and adolescent mental health services. On page 9, it talks about additional staff in terms of autism, and also the same page, I think, or the following page, it talks about adult ADHD services. And with those, you're looking at collaborative partnerships with other services and with other partners. Whilst all that is good, what the paper doesn't do for me is give me an understanding of, as a result of these interventions, when can the board expect to see, for example, in terms of specialist CAMs, a reduction in our waiting times? When can we expect that trajectory to improve? And so an understanding of the impact on performance of what you're talking about in this paper, I think would be helpful for the board.
I'll start. Thank you, Esco, and I'll start to answer that question. I'm sure some of the team may want to come in. So I think I'm very mindful of, and I know the team are very mindful of, that one of the things we need to be able to do is to describe when those actions are going to impact and provide some kind of trajectory of improvement. The challenge I think we've got, and I know we've discussed this through the Quality and Safety Committee, but one of the challenges with the management of the mental health position is the sheer variation in the type of intervention and treatments people get, and also the different lengths of time that people may be needing to access the service for support. So providing a really thorough and detailed demand and capacity analysis and piece of work is a challenge, and that's compounded somewhat at the moment, or has been, by the transfer of the service to the WPAS system. I'm hoping, or expecting, not hoping, because I've had confirmation that by the 11th of April, the first of the service areas, I think neurodevelopmental services, which is one of the areas we're concerned about in terms of waiting times, will be on that system, and we are working through then how we properly articulate the impact those actions are going to have on the improvement timeframes for those access times for those services. I think the other piece that we are doing as well as part of the benchmarking work is reaching out to other organisations and understanding what it is that they're doing. So those areas that are performing better than us, we are looking to see what they do, and there's some interesting feedback in some of that already, in terms of one of the health boards that's particularly good in this area doesn't offer any individual one-to-one appointments. They only offer group therapy intervention. So there'll be a conversation we'll need to have as a service about how we shift from a mixed model to that model, if that addresses on the balance of risk, addresses the position better than the current provision we're providing. But I'm sure there will be equally a quality assessment in terms of the service that we're providing as well, that the team will want to use to underpin that. So in short, I haven't got an answer to that specific question at the moment. I've asked the team to continue working on that, and I've asked for an update through my monthly business meeting in April, setting that out and with a bit more clarity as far as we can. But it's a very complex and difficult question to answer, if you like, in terms of the detail. It's not like going to scheduled care and asking them to tell us about what they're going to do with trauma and orthopaedics or eye care. It's a completely different level of complexity in terms of answering that question. I don't know whether any of the team would like to add to that.
I'm happy to give a little bit of good news around details of appointments and where we are into our ASD and ADHD services, and some of the creative approaches that we're trying to take in relation to our recruitment problems, if that's helpful.
Well, I guess, Chair, what I'm asking is, accepting that this may be difficult, we need to have an understanding of how interventions are impacting on patients, and I would have expected that in this paper. Accepting it may be difficult, but I think we as a board need to give assurance, whatever the difficulties, when they are likely to be seen and what that performance is going to look like. This must be the same for other health boards. And so I think looking to see how others are doing it and how we can provide an indication for all of us would agree, very vulnerable individuals, and that will need these services. For me, I would have hoped we would have seen some detail on that in this paper.
Thank you, John. Judith.
Yeah, thank you. I think Andrew's really outlined in his introduction some of the sort of thoughts I had on the paper in terms of it being quite difficult to just see where we are against the strategy as agreed. This paper sets out a huge amount of work that's going on across a range of areas for mental health, LD and CAMS, and to pick out some of the specifics is quite hard, and to see it against the plans that are in place or the plans that we agreed would be really helpful. So maybe that's something to take forward. I think, you know, I do want to say, because we've had information in the past to the board, I do think I need to say how much hard work has gone in by the directorate over this last 2 years in managing the COVID situation, not only in the way the wards were managed to keep it until very recently COVID free, but also in the way that the team stood up and worked in different ways. I know there's a process now to properly embed different ways of working. If I may, there's something specific I want to say about LD. There's mention in the paper of the Dream Team, and I know I've said this before, but I do think we do need to see where we are against the pledge we signed up to with the Dream Team. Maybe that is something sort of in conversation with Joe, we could look to where that comes back, whether that comes to the board, whether it goes into the quality committee, but it's some time since we actually had an assessment against the pledges that we signed up to. I think the other thing that would be helpful on the estate side, and I'm aware of some of the, well, a lot of the concerns about accommodation, but again, similar to what John said about the trajectory of improvements, the timescale of when we expect to see any new developments coming on, the link into some of the ones that already exist, or the plans such as Cross Hands and others. It would be helpful to see where the time scale is for those plans to improve our accommodation. So not really specific questions, but I think a general flavour that there's maybe more that could, not more detail, but more in terms of the framework of where we are as a health board against our various plans that we've agreed to. Sorry, my voice is going a bit. I'm catching it from Mandy.
Thanks, Judy. Are there any other questions from members? Could I ask a question about patient feedback? There's a list of methods in which we gain patient feedback, and I'm not, but it doesn't tell us what patients are saying about the services. I just wondered, where does that go?
I know Sarah will probably want to come in and answer that question.
Thank you very much, Chair. Yes, so the feedback that comes in, both through compliments, concerns, advocacy, it goes to a variety of places, but most importantly, it goes to our operational heads of service, which is then disseminated through their quality meetings, because that is where the learning takes place. We obviously do thematic work through our quality assurance practice development team, who are there in a supportive function. I reviewed the compliments today, which is lovely, which are on the Civica system, and we hear a lot of words when people are complimenting us, talking about kindness, feeling reassured, that compassionate approach to our service users and their carers. With regards to our concerns and complaints, a lot of that is around communication between our services, our whole system working that we need to improve, and obviously we have an overarching improvement plan which we check and challenge our perceptions and assumptions against. I hope that's helpful, or if you want any further detail.
It is helpful, and I think the paper would have benefited if we'd had a summary of the feedback, and I would expect there should be feedback about the long waits. I don't know if we go out to those people on the lists as well, There's a comment in the message bar from Anna. I'm going to bring Anna in.
Thank you, Chair. And I suppose I just want to preface my comment by saying that I think it's entirely possible for us to acknowledge as a board the enormous amount of work that the team are doing now and have been doing for many years. And I joined the board around the time that TMH, I think, was really starting to be implemented. So that all stands, and I firmly believe that that is the case. However, as a board, I think that in the absence of any form of trajectory about how we move from some very low baselines that have come about for all sorts of different reasons, and COVID clearly hasn't helped, to a more confident position where we can be confident that the patients get the care they need in the timely manner that they need it. We do have a blind spot about that. And while across our board business we deal with all kinds of really pressing risks that cause disquiet and discomfort to all of us, I think we do at least feel we know about them. And this feels as if it's one where the line of sight between board and frontline operations is not as clear as it needs to be, and that we all need to think together about how we tackle that, not only by looking at the operational team to find some magic, but to think about how we as a board, through our committee structures, my own committee included, can work together to get clearer about what the sort of prognosis is for these services and for the people who are waiting or need to access care, given the very significant risks that are often waiting in mental health caseloads and that are very risky all round.
Anna, I'm going to bring in Steve.
Andrew, did you want to come in first? Or?
All I wanted to say was I fully acknowledge and accept the comments that Anna's made. I fully accept the challenge that Professor Gammon has given earlier in the meeting as well on this specific issue, and I know it's something that as a directorate team they're working very hard on. We can't escape the fact though that the transfer to WPAS is a significant constraint in having the information available to enable that work to be undertaken. I know Liz is looking at, after a conversation last week, is looking at whether from within the directorate they can support an additional post through the digital team to help roll that out and expedite the delivery of that if that is the constraint. But it is going to pose a challenge until those services are transferred for us to be able to get the information we need to the level we need it to be able to provide some of that assurance that we all know and the board are looking for and that we would like to give them.
Yeah, thank you. I think for Andrew and for the team, just to say that this is a board that's very supportive of everything that you have been doing and are doing. This is not a criticism of the sheer amount of work and the challenges you face, not just in the pandemic, but also as Andrew alluded to, just in the sheer workforce challenges that we all face. I had a couple of practical suggestions to help us sort of take this forward so that the board can get the assurance it needs, but also support the team. So I think, Andrew, something around the trajectories for the rollout of WPAS would be helpful to understand, perhaps through a relevant committee, and our opportunities to accelerate that if we need to. What would that take, given that that seems to be a rate limiting step, so we can test that a little. On the issue around TMH and its delivery, I think there's been an enormous amount of work, and that was a really ambitious programme in and of itself, working from one of the world exemplar sites in Trieste's whole approach. I just wonder on that whether we can take the recommendations, as you suggested, Andrew, through a committee and show how we've delivered them, partly to give a bit of closure to it as much as anything, so sort of declutters the fields a bit. And then I think on the issue around trajectories, I think the feelings of the board, I think, are sort of heartfelt around needing to understand where the issues are more clearly, but understanding the challenges that Andrew set out. I think what Andrew said at the beginning is really important for me, and I think this might be a way of bringing this forward. Wrapping the improving together process around the team now, I think will allow us to do a couple of things. One is to recognise that there are Welsh Government requirements and counting requirements, and we need trajectories around those things because we are held to account on those areas. Recognising they're only part of the story, and actually quite often not the most important part if you're looking at it from a clinical point of view, but we need that addressed. But for the improving together process itself, to bring out what are the things that are most important to the clients, to our patients that we're trying to achieve. What are those performance targets that would look important from their point of view, and what is important from the service in terms of what they're trying to achieve, and developing some more meaningful trajectories around those things through the improving together process. I think would give a really helpful focus to this, so we're not just hidebound by either the partial measures that Welsh Government put in place, or indeed having nothing at all. So I wonder, Andrew, whether we could accelerate that piece of work and come back to board at the next meeting if possible. But we may need to just judge how much I'm asking here. With this is what we think of the performance metrics might be and what our trajectories might be. But I guess what I'm saying is we don't need to be hidebound by what it is that we're being asked to record by Welsh Government. I think we can be much more rounded and give a much more rich view, given that it is a very different service from trauma orthopaedics.
And thank you, Steve. And if I could just add to that, there's a suggestion in the message bar from Mandy about the patient voice. It's the right place to bring back the progress focus on the impact and staff. I'd like to hear the patient voice, and it's good to hear, really lovely to hear about, you know, the kindness and a lot of the positives. It's be good for the board to see that as well. So maybe that could be part of that report that comes back to board, or it could go to Quasar. I think I'd like it at board. I think it's really important that we celebrate some of that. I was with the Minister for Mental Health, the Deputy Minister, last week, and one of the things that she raised is ensuring that the waiting lists are validated and that triage is in place, so there is prioritisation. So I'd be grateful if you could address that when the paper comes back as well. And the learning, really welcome the learning, because if you look at performance across Wales, many of the health boards, if not all of them, in many of the areas are doing better than us. So that learning is important. And as you say, Andrew, it's the quality. You know, if we think it's good rather than just because of figures, and that's the most important thing. And I want to reiterate, you know, you as a directorate have done incredible things, both in the implementation of TMH and throughout the pandemic. So this is really to support. We have a duty as a board to be cited on these things in more detail, rather than the process. The process leads to the outcomes. So we really welcome that coming back with the suggestions that Steve's made for extra support to the team. Is that okay, Andrew?
Yeah, that's fine. No problem.
Okay, thank you. Thanks very much. Does the team wish to add anything?
Thank you, Chair, and thank you very much for the comments, questions and suggestions. For us, the most important thing is in terms of how we best deliver our services to our population and meet their needs. We fully accept the current challenges in terms of the waiting lists, and we would rather there be no waiting lists within our service areas across the age span. That's what we're trying very hard to rectify and address. We've raised the constraints and some of the limiting factors and some of the barriers to that, but our ambition and objective is to address that and progress this. We thank you for the opportunity to further crystallise the waiting time position, and to inform that on the ongoing capacity and demand work we're doing within the service areas, and how best we progress that, and how best we as we are currently doing is in terms of, Chair, as you mentioned, in terms of those on the waiting list, is to make sure we triage and we prioritise our services to the most in need of our services, but also accepting that we've got a number of people waiting for our services for a prolonged period of time. And that's something we are actively trying to address and we are aware of the impact, both direct and indirect, for those people on waiting lists. But we thank you for the opportunity, and thank you for inviting us back to further address the issues raised, and for the suggestion in terms of accessing provision within the health board to further strengthen the recovery position in mental health and disabilities.
Thank you, Warren, and thank you, Sarah, and thank you, Kay. And I just want to reinforce that we're here to support you and give you extra support that we can, so that we can all collectively ensure that people are not waiting as long as they are at the moment. So thank you very much. Diolch yn fawr.
Thank you.
If we now go on to the next item on the agenda, which is the corporate risk register.
Yeah, thank you, Chair. So since the service officer was last presented to the board in November 21, the risks have been discussed in detail at the board level committees, and where assurance has not been provided, for example, there's some good areas in quality and safety, for example, in mental health and radiology. A deep dive has been requested by the chair of that committee. So just in summary, there are 18 risks currently on the corporate risk register. If we just remind members, the corporate risk register is more about the here and now. 10 new risks on the risk register, 4 have been de-escalated, 2 reduced, and 8 have no change, and they've all been reviewed. They are all reviewed on a monthly basis at the exec risk group as well. I'm just thinking back to the earlier agenda on NSTEMI, that is one of our corporate risks, and there are a few there which we've discussed as part of the board meeting already today, Chair.
Thank you, Jo. Are there any questions on this? Thank you very much. It's often on papers which technically are excellent and analyse and keep us safe that we don't ask questions. It doesn't mean we don't appreciate the huge amount of scrutiny that goes into them. So thank you.
And just for the public's assurance, there is a lot of scrutiny done at committee level on the corporate risk, Chair.
Thank you very much, and thank you everybody on the various committees. If we can now go on to the integrated performance assurance report, and that's over to you, Hugh.
Diolch, Cadeirydd. Yeah, I've just outlined there the 5 key drivers that are affecting our performance, and much of the discussion that we've had today is, as I've probably touched on a number of those in our deliberations on the operational pressures that are being faced, and indeed the conversation we've just had around the challenges within mental health and learning disabilities as well. Just goes without saying that clearly, while we're looking at statistics, there are individuals at the end of each of these statistics, and are very mindful of that. If I go into page 3, I do want to highlight a couple of improving measures that we've noted, and in particular the patient experience measure, which despite the challenges within the system, actually patients are reporting that they are being listened to, that they're involved in decisions around their care, and that they feel safe and well cared for, and that those are improving measures. So our staff are working incredibly hard under difficult circumstances, but are still making sure that patients are at the front of their minds. And with that, Chair, I think I'll just open it up to discussion, because I do recognise that many of these areas have been discussed already this morning.
Thank you, Hugh. Open to questions, colleagues.
Just to link back to the IMTV discussion we had a discussion yesterday at the exec team, and board members would have seen there's a set of indicators that are coming out of this sort of higher level ones, the things that we're expecting to improve in the next year. We're working with Olwena and the comms team on putting together a recovery communication strategy, so that we can be communicating with the public about those things that will be changing, because we're taking direct action and the speed with which we expect that to change. Still a bit more work to do on that, but that's coming together as part of the IMTP.
Okay, thank you. And that would be helpful for the board to scrutinise rather than the government targets, which is difficult to ask questions on these at the moment, because we know the context in which we as an organisation and others find themselves. Any questions?
Yeah,
you just want to come in. Please come in.
just to add, Chair, what you're seeing here is a high-level presentation through the SBAR. There is a link in there into the underlying dashboard from which all this information is taken, and that link is available for the public to access as well, which includes all the detail on the range of measures that we are tracking.
Thank you. There's one item on page 3 of 6 in relation to the consultants and SAS doctors with a job plan, and I just wondered if we can connect that with some of the issues that's been raised with Lisa and I in relation to the quality of the job plan and the methods of the job plan. So I'll just leave you two to connect over that, unless Lisa wants to come in.
I was just going to say, Chair, I've added that to the list of things that I'm working with our SAS doctors around, and I'll be picking it up with Phil.
Thank you, that's great. Are there any other questions on this report? Thank you very much. If we now go on to the financial reports, and that's Hugh.
Yes, I'll just take you through briefly the finance report. I think the message that that is coming through the finance report is consistent with the message that's been given for the last few board meetings. The one thing just to highlight is that we were in a position to ask government for an additional £4.5 million to continue with the progress that had been made on our recovery actions. If you recall, we had a conversation in the board meeting in December where I wasn't in a position to provide assurance that we could spend the entire allocation that we had requested at that point for recovery. And we provided some funding back to government. Actually, as we got into month 11, it was clear that the trajectory being followed by the operational teams and the hard work that had been done by teams under Andrew's direction meant that we were in a position to be able to draw back some of that funding that we'd originally provided back, and that's allowed us to continue with the pace of outsourcing activity in particular, but has also allowed us to look at accelerating some of the scanning activity that we've been undertaking, in particular referencing back to the report that we had earlier from the audit committee on records management, and it's addressing some of those challenges that we've had there. Some phenomenal work done by the team there, and I think it's worthy of a report to come back to a committee in the future on the work that has been taken to address that risk in particular.
I'm sure we'd welcome that. Any questions? Maynard.
Yeah, just a quick one, Hugh, on the key financial targets. Capital was the only one of medium risk when the paper was written. We're now right at the end of the financial year. I'm just wondering how that is panning out.
Yeah, thank you for that question. Yeah, the progress is being maintained. It is a risk, and there still is a risk there, and the way we've been managing some of that risk is by vesting equipment towards the end of the year where that hasn't been delivered on site, or we don't think it's going to be delivered on site. We have taken ownership of that equipment, even though it remains within our suppliers' warehouses or storage facilities. The value of that vesting is somewhere in the region of 7 million, and I am preparing a report to go back to audit committee at the next committee as part of my normal report, just to outline the measures that we've taken to manage that risk.
Thanks, Hugh.
Winston?
Yeah, thank you, Chair. Thanks, Hugh, for really clear reports and consistency there. My question is, I'm just aware that inflation has been increasing quite steadily. So it was 5.4%, I think, in December, 5.5% in January, and now up to 6% in February, and probably something higher than that. Well, my question is, what's the impact of it on our forecasts that we've got? I don't think it will have a massive impact more on future years, but more importantly, with that in mind, how are we thinking of supporting our staff, especially those who are at the lowest end of the pay bracket, and also those who are caring for those carers for our patients?
Thank you, Chair. Maybe bring colleagues in as well in terms of the impact on us in particular there. It's not having a material impact on our performance to the end of March, largely because we were able to buy forward our energy prices, as our energy supply, as I alluded to earlier, and that's going into April. So we've been able to cap that risk. We are seeing that cost pressure coming through in certain areas, but not in a material sense towards the end of this financial year. As I said, it's going to be a material issue for us going into next year. Clearly, the impact on our staff and the impact on our communities is going to be significant, and that's something I know that there's some work that has started under Lisa's leadership, and indeed Joe as well, Joe McCarthy, and if I just hand over to Lisa in terms of how we're supporting our staff.
Thank you. So there's a few things that we're looking at really. First of all, just to let everyone know that Welsh Government have announced this morning that the real living wage is being increased from tomorrow. So that's ahead of any recommendations from the pay review body. So it will support, as Hugh said, the staff on our lower pay bands with effect from tomorrow. There is also work that we began in our health board and is now also being considered across Wales, whether there's anything that we can do to support people, particularly with travel costs. So we know that our community members of staff are particularly affected by the increased fuel costs. So that is being looked at to see what can be introduced relatively quickly. In addition to that, we're setting up a task and finish group, which Rob Blake, who leads on our staff benefits, will be a member of, and that's to see how we can ensure that our staff are aware of all of the things that are available to them, like credit unions, financial advice, staff benefits and discounts, so that everybody knows that there are ways that they can also look at saving money on some of their general household bills. So once that group's up and running, we'll have some very quick actions to try to support our staff in the best way we can.
Thank you both very much. Thank you.
Lisa, I was at a meeting on Monday with the NHS Confed across the UK. It was about the public inquiry, but it was discussed about schemes across the UK as well for employees. So we've asked that best practice will be shared with us. But well done, and we also know that will increase the inequalities and health outcomes, unfortunately. Any other questions on the financial report for Hugh? Okay, thank you. The board's happy to accept the recommendation. We then go on to the strategic enabling update. That's Hugh again.
Great, Chair. I think the report is pretty clear. I'm happy to just open that up straight to discussion, recognising time.
Thank you, Hugh. Any questions on this? Not board happy to note it. Many thanks. Thank you, Hugh. If we go on to the report of the Strategic Development and Operational Delivery Committee, Maynard.
Thanks, Chair. I think in the interest of time, I won't draw anything out. There are 3 substantive items following this which have come from my committee, but the concerns there I think have already been touched on. The only one that's probably worth an extra mention is the stroke service redesign and the HASU facilities that may not be available in Swansea now, and that we need to keep an eye on.
Yeah, thank you. Do we have an update on that, Steve? Because it seems as though HASU may be available to us.
We haven't got anything formal, but
okay.
Yeah, I think the sands are shifting. I think once we've got a bit of a clearer idea, we'll update the board on where that is going. But yeah, we did have a bit of a shift in thinking, at least informally, from Swansea Bay recently.
That's great, thank you. Alison, did you want to comment on that quickly? No, okay. And thank you for scrutinising the dementia strategy on our behalf, and also the palliative care strategy. Much appreciated. Okay, the next item on the agenda is the dementia strategy. Alison.
Thank you, Chair. Yeah, I mean, everybody will have read it and gone through the detail. I just really wanted to thank Rhian for her leadership on this. It's been a tremendous piece of work. You can see it's very detailed, and I think it's fair to say that the strategy has got quite a challenging and ambitious agenda attached to it, but it is evidence-based and it has been informed by people locally that are living with dementia. So I'm grateful to Rhian for joining us in case there are any questions, because she's been leading on this and is obviously very close to it. So happy to take any questions.
Thanks, Alison. Welcome, Rhian. I'm going to open for questions. And you know, I think that's it. There are no questions there. Well, there's a well done to you, Rhian, in the message bar, but the questions are because it's so good, I think, and also it's gone through scrutiny. But if you want to briefly add anything to it, it's such an important strategy. For me, it's the delivery and the restrictions and the challenges in that delivery, you know, but we've got to have the dream. John, did you want to come in on this, or are you waiting for your next report?
No, it was just to say that this report has been to other committees and comments have been made, and I can see that those have been considered, Rhian. So I just want to make that note, particularly around the issues of carers, I think, which is the point that was being made. So it's reassuring that that is being considered within a very robust strategy, I have to say. So thank you.
Thanks, John. And I just suppose the only thing that I would want to mention is that I represent the West Wales Regional Care Partnership in this work, really, and what, you know, it is a challenging agenda, Marie, just as you suggested, but we have to dream, and it's absolutely the right thing to do. And I think, you know, the main premise is that prevention and proactive care element, which is, as we know, the only way for us to make best use of resources, acknowledging that the reactive nature sometimes of what we do increases the demand on the finite amount of care resource that we have got. So I look forward to taking forward this agenda with my regional colleagues. And it is a really positive position to be in, knowing that we are all on the same page with the same intent to deliver improved outcomes for our population on this.
Thanks, Rhian. Absolutely agree. Judith?
Yeah, thank you. And just to add my thanks to Rhian and the team who've done the work on this. As Rhian said, it will be going, as the paper says, it will be going to the Regional Partnership Board, and I just wanted to emphasise that as part of the new funding arrangements for the regional RIF, the Regional Integrated Fund, there is money set aside specifically for dementia, so it's ring-fenced. So through the arrangements we discussed earlier, that will be how we make sure that the money is spent appropriately to deliver the strategy. Thank you.
Thank you, Judith. I'll just bring in Steve.
Yeah, just say thanks, Rhian, thanks, Alison, for this. Really good to see it. It'd be good to get a bit of an update at the right point. I know some of these things will take some time to come to fruition, but come back to board with kind of how it's going, both in the delivery of the sort of specific inputs, but also how we're starting to see the effects, the outcomes and outputs from it. And I just wonder as well whether there's a conversation to have with the performance team, and indeed maybe with the board secretary linked to the board assurance framework, about parts of this we can pull out so that we can keep an eye on the outcomes in the long term, because this will be a long-term plan, won't it? That will have effects down the years. So trying to link it in as far as we can to our performance system, board assurance, would be really helpful.
Thanks, Steve. And if we could also bring in some of the challenges of delivery into the workshops that we're going to be holding with our local authority partners, because I feel that they are going to be, you're probably going to be able to tell us them now, Rhian, but you know, if we link it into this, I think it will help as well. So the board's happy to approve the dementia strategy, the West Wales Care Partnership Dementia Strategy. Thank you, and massive thanks to Alison and Rhian for all the work you've done, and we'll go forward now to deliver the dream. Diolch yn fawr. Thank you. So the next item on the agenda of the palliative and end of life care strategy, again, which has been considered.
Thank you, Chair. Sorry, thank you, Chair. Yes, again, this has been to the SDOD committee previously for scrutiny, and I just want to commend this to the board today. We brought forward a set of principles in 2020 with the ambition that we would develop a strategy which has been absent, and something that's been picked up through the national audit for care at the end of life, which goes through our quality and safety committee. So we are on track to deliver a business case that we hope will come now at the end of this quarter. We will set out a set of options for us. There have been a wide series of engagement with partner organisations, with patients' families, and with a wide range of staff stakeholders as well. And one of the things that we're also building on through an All Wales piece of work is an outcome domains framework for palliative care, which we'll be able to build into the strategy. This isn't without challenge for us, because palliative care services, which have really come into their own throughout COVID, are distributed really across our health board. Primarily there's resource within our communities, but it doesn't properly reflect the wide extent of this service within it, which reaches into our acute services as well. We've seen some welcome growth in our medical workforce, but still have some significant workforce challenges in our specialist palliative care nursing workforce. But we're doing some work with our education providers and leaders within Mandy's team as well to help us look at the career framework for specialist palliative care nursing and the outcomes that we would want to develop from that. So I'd want to commend this to you today, with further work to be coming forward through the relevant committees in terms of the business case and the development that we will need now to take this strategy forward. But I really wanted to commend the principles of what we've developed with wide engagement, and it's such an important strategy for our board to be taking forward.
Many thanks, Jill. Jill, are we the only one in Wales to have a end of life strategy?
Yes. We're really ahead in terms of that, and it has gained a level of interest from the National End of Life Care Board. So, you know, we're wanting to share this good work, as we have been doing, with our colleagues across Wales. But what's also been recognised is the way that we've brought together our regional, our team across the Health Board, which, as I say, has been quite disparate before, but really got our specialist consultants together, our specialist nurses, to look at that regional approach which can be locally delivered, and that's been quite an ambitious piece of work, and I've really welcomed the support of all of the teams really in being able to take this forward.
Thank you, Jill. Steve, did you want to come in?
Yeah, just firstly to thank Jill for what she's done here. I remember meeting our palliative care clinical teams probably a few years ago now, and fair to say they felt disconnected from the health board. They felt they didn't know the way in, and they were sort of somewhat sidelined. And Jill very bravely stepped into the breach for me and picked this up as exec lead for it. And I have to say, over the last couple of years, has done a remarkable job to get us to this point, and now to be leading Wales on a strategic way forward. And I know the feedback from the staff is just how much more connected they feel and how much more part of the whole of our family. So thank you for that, Jill. I guess my only comment would be the same as the previous one, is that to now start to pull out of this the process measure and potentially some outcomes that can link to the BAF would be really helpful, so we can keep our eye on the overall direction of travel as we deliver this. But really commendable work, well done.
Thank you, and that All Wales piece of work on the domains framework will enable us to develop that framework, Steve, to bring into the BAF, which will be very important. And if I could just mention one other area, because I did admit that at the beginning, I think this is very timely, because our patient story, this board, was very much about things that didn't go as well as they could have done. And I think we've reflected on the learning from that patient story as well in our journey with the teams as a consequence of that. So that learning is so important in terms of helping us to build on the aspirations that we've got through this strategy.
Thank you, Jill. I'm going to bring in Judith.
Yes, thank you. And yeah, I'd like to endorse everything that's been said. I would also like to make a point, I don't know if others have noticed, but I do find the way that Attain help us set out these documents makes them incredibly readable, and also I have to say very eye-catching in the design. But I think again this does demonstrate, and I think this is one of the another reason we're ahead of the curve, real engagement that Jill has led across the region, So this is a How Thou strategy, but it involves other partners, and I think that's to be commended. And I think it's a really excellent piece of work and quite an easy read, which to me is always very important with a strategy document.
So thank you, Jill, to you and the whole team for leading the way on this and that continuous learning. And as Steve said, if we could look at bringing it back as well to the board. Many thanks. The next item on the agenda is the Regional Partnership Board Population Assessment. Jill?
Sorry, I just turned my camera off for a moment. Again, thank you. I'm bringing this to you. It is going through all of the committees of our stakeholder, our partners within the Regional Partnership Board. So is on a journey through our local authorities as well as the Health Board. It's a really important piece of work. The legal context is set out for you in the framework, and we have to undertake a population needs assessment every 5 years within each election cycle. So this is the second one that has been undertaken within this Regional Partnership Board. And you can see from the S-bar that there are some specific groups that have to be considered. And the second request that we also had was to develop a market stability report. And that looks at the sufficiency of services, but also in terms of the specific groups that are identified in the population needs assessment. We have to consider the stability. And again, I know throughout the board today, we've talked about the fragility of a lot of the services that are reflected within this report. It's also important because in all of the developments going forward within our own Health Board strategy, but also in things such as the RIF funding that we've talked about in terms of cluster plans, we are going to have to give cognizance to this population needs assessment and also the market stability report. And there'll be an expectation that any funding that we're seeking through those resources reflects some of the outcomes and needs that are identified through this assessment. So there's a wealth of information here that isn't just about a report that's important to take through our partner organisations and the Regional Partnership Board, but must be fundamental actually to the way in which we plan our services so that we're addressing the needs of the population going forward, but also the particular challenges that we're facing in terms of some of the sufficiency and the stability of the services that have been identified through this report. So again, I bring it to you today formally. It needs to go through our Health Board and each of the local authorities as members of the Regional Partnership Board, and it's a formal report that we bring to you today for sign off. It has been taken through an earlier SDOD report as well. Thank you.
Thank you, Jill. Is the board happy to endorse and accept the recommendations? Many thanks. Thank you, Jill. Next item on the agenda is the report of the People Committee.
Chair,
sorry,
Paul had a comment on the last item.
Oh, John, sorry, Paul, did you want to come in? Excuse me.
Just a couple of quick comments.
Yeah, of course.
The population needs assessment references unpaid carers, and the statistics which are used in there go back to the 2011 census. And we know from one of the consequences of COVID was that the number of unpaid carers who made themselves known increased significantly. So it's a concern that the figures which have been relied upon in the population needs assessment may in fact be an understatement of the number of unpaid carers. And linked to that, the market stability report talks about the various different services and provisions which might be made, but it makes no reference to respite provision. Which is probably one of the most important provisions for unpaid carers to enable them to continue in their caring role. And if unpaid carers feel unable to continue in their caring role, that will inevitably lead to the sorts of increases which the market stability report as drafted seeks to address. So it seems to me that there may be a little bit of a gap there that perhaps should be considered.
Thank you. I'll respond briefly, Paul. Those are important points, and as you rightly said, through COVID, and particularly when the vaccination became available, priority groups were carers, and we saw an enormous number of individuals who were not known to us previously come through that route. So it's an important point in terms of recognising the hidden number of unpaid carers that are within our population, and also the importance of respite care and how we address that and pick that up as part of the service assessment of the stability and sufficiency of that respite care for carers. So we'll definitely take that feedback back into our regional partnership board.
Thank you. Thanks, Paul. So the next item on the agenda is the report of the Pupil Committee. John?
Thank you, Chair. So this report is a summary of the committee's activity on the 3rd of February. I'm happy to take questions. There are no matters requiring board consideration or approval, or any matters that we would raise as concern.
Thank you, John. Are there any questions? No, thank you, John. The next item on the agenda is the Health and Safety Committee. Judith?
Thank you, Chair. Yes, the report's here for any questions and also for information. If I could just draw attention to one item, and it's the issue around lifting operations and lifting equipment. The previous report to board, we did flag this as an area of concern, but the committee did receive an update which demonstrated that all the issues we had are definitely in hand to be addressed, and so the committee was able to take assurance that this was now no longer such a high risk area as we had felt at the time.
Thanks,
Happy
Judith.
to take any questions.
Any questions? No, thanks, Judith. That's really good to hear. Next item on the agenda is the report of the Sustainable Resources Committee. Winston.
Thank you, Chair. The report's quite self-explanatory. I do wish to just draw out 3 areas that we looked at in particular. The first was that we received quite a detailed presentation from NHS Wales Shared Service, and we did encourage that they continue to work with us towards supporting our foundational economy opportunities, such that there was certainly more procurement or more work being done in because actually 10% of our contracted work is only done within the environmental footprint of Mid and West Wales, and we wish to encourage them that more of that happens through their procurement service to us. That's the first thing I want to say. The second item I just wanted to bring to people's attention was that we did receive a very, very helpful and encouraging update on our decarbonisation initiatives. Whilst we haven't got a strategy as a health board as yet, it was really helpful and uplifting to know what work we are doing and that we are working with the Carbon Trust towards developing a plan for that. So we look forward to receiving that strategy at the committee, but also in informing the board as well in the months to come. And finally, on a more sort of down point, which is in terms of information governance subcommittee report, we note this sort of increased risk of cybersecurity resulting from what's happening in the main part of Europe and Ukraine and Russia, and we just wish to bring that as a sort of heightened security risk for the board. Happy to take any questions on any other items for the committee.
Thanks, Winston. Are there any questions? Thank you for the comprehensive report. If we now go on to the committee updates reports, are there any questions on any of those reports at all, or comments?
Chair, they're just sorry, the 2 matters, the kind of charitable funds which we're going to trustee session, and just the issues raised from the SRG's perspective that they were specifically asked to raise the board's attention. So just want to make sure we lifted those in relation to the support that the stakeholder reference group can give in relation to delivery of the IOTP and the payment voice.
Yeah, thank you. And I'm sure we're going to take that forward. Yeah, thank you. Any other issues at all? Okay, thank you. We then go on to the joint committees and collaboratives.
Happy to take any questions, Chair.
Any questions at all? No, thank you. And the statutory partnerships update. Okay. And then the board annual plan. Thank you, Mark. The board annual plan. Everyone happy with that? Thank you. Okay, so I'm going to draw this meeting to an end. Can I thank members? I know it seemed a wee bit rushed at the end, but I think we spent the right time discussing some of the really, the things that we needed to discuss during the board. So, diolch yn fawr, and we will now go into the trustee meeting. I'll get the trustee papers. Okay. Apologies for absence is the ones we had before, plus those members who've had to leave during the process of the meeting.
Yeah, so we've now lost you and Gareth, Chair.
Okay, and Mark.
And Mark,
Yeah.
Chair.
That's grand, thank you. Any declarations of interest? Okay, item number 2.1 is the ratification of charitable funds requests, as we need to do in accordance with our governance over £100,000. So if I go over to you, Mandy.
Yes, thank you, and I'll be very quick because I think the papers are fairly self-explanatory. We were very pleased to receive this application, or at least understand why £110,329 was going to be required. But actually, when the case was put forward for the echocardiogram machine and the ECG machine for paediatrics, it was obvious that this was the right thing to do, to actually improve the experience of patients and our staff, and actually support improving outcomes for our young population. So we would like this to be supported as corporate trustees as the appropriate purchase.
Thank you, Mandy. Reading the detail of the current methods in which this is undertaken, it really does emphasise the need for a dedicated machinery, and it's good to see it locally as well. Any questions? The trustee happy to approve? Yeah, thank you. Thanks, Mandy. And the next item on the agenda is the consideration of the charitable funds expenditure.
So again, this is very brief. It's really just to confirm the amount that's required to support the governance and support costs to enable the charity to actually function. So it's very similar, with inflationary rates built into the amount allocated last year. So again, it's just to ensure that the corporate trustee is happy with that allocation.
Thank you. Is the trustee happy to approve the recommendation? Many thanks. So we'll now go into in-committee board. So 5 minutes break before then. Is that okay?
Yeah, please.
Yeah. Thank you very much, everybody. Diolch yn fawr.